everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, we'd like to welcome you to today's virtual workshop titled Effects of Prenatal Substance Misuse on Children from Conception through Adulthood with Catherine Shea. This virtual workshop is being made available through a collaboration between the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, I would like to mention that this presentation and handouts were sent to all registrants via constant contact communication. If you haven't done so already, it is important that you print these documents prior to the presentation, as you will need them to participate in activities. Today's training will include both presentation time as well as group activities. You will be able to interact with the presenter by responding to polls and typing your questions in the chat panel. Please note that during the presentation, as an attendee, you are in listen-only mode. You will not be able to communicate verbally. Any questions or comments may be shared through the chat panel. Our team will be monitoring the chat, and the presenter will answer them as time permits. Today's presentation is from 1 to 5 p.m. and will include 2 15-minute breaks. Your video access will be disabled during the presentation, and you will only be able to see the presenter via video, and you will only be able to view your name and the name of the other attendees during this time. However, during the breakout sessions, you will have the opportunity to enable your audio and video for interaction with the group. The virtual workshop is designed to be interactive, and we highly encourage your participation. We encourage you to share your video during the group discussions. The group discussions will not be recorded. Our audio is broadcast through the internet to your computer. To hear the presentation, please make sure your volume is not muted. During the group discussion, you may use your audio and video by clicking the mute and unmute button for audio and the start video button to begin your video as seen in the description. If you experience poor computer audio, you may want to consider calling in to hear the presentation. But please remember, in order to get a certificate of attendance, you must also view the presentation on screen. Today's presentation will be available on the FATA website within 30 business days. To access the recording, PowerPoint, and other handouts, please go to www.fata.org, then to our Resource Center, and then to our training library. FATA produces many webinars and workshops with the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain a statement of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. If you haven't already done so, you will need to register with our website at www.fata.org and create a profile. Information you provide to FATA as a part of registration remains confidential. At the end of today's workshop, you will have an opportunity to complete the presentation evaluation. You will receive an evaluation link in the chat panel at the conclusion of the workshop, and you will also be redirected to the link. Additionally, you will get an email that will go to the email address you used to log into today's workshop. When completing the evaluation, please remember to use the same email you used when you registered for our workshop. The evaluation must be completed by midnight, Thursday, November 4th. Statements of credit will be available within 30 business days after the evaluation window closes in individual professional development journals for persons completing the evaluation and attending the full workshop. Completing the evaluation is necessary to receive CE credits or to receive your statement of credit. Please remember the evaluation will close midnight on Thursday, November 4th. Up to 3.5 continuing education credits are available for participating in today's workshop for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker in your evaluation. If you've certified with the Florida Certification Board or licensed outside of the state of Florida, you don't need to provide us with your certification number when completing. Please note, Zoom monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire workshop. We are not permitted to provide partial credit. Catherine Shea has worked with children with serious emotional and behavioral disorders, including fetal alcohol and drug effects, for over 40 years. Ms. Shea has received numerous awards for her work in infant mental health, fetal alcohol syndrome, and child advocacy. She currently serves on the board of FASD United, formerly NOFAS, and is an independent consultant at the local, state, and national level. Ms. Shea served as president and CEO of the Florida Center for Early Childhood for 12 years and is a past president of the Florida Association Infant Mental Health. She received her bachelor's degree in psychology and a master's degree in social work from the University of Kentucky. And now I would like to welcome Catherine. I will turn the presentation over to you.
Thank you so much, Rebecca, and welcome everyone to this afternoon's workshop entitled The Effects of Prenatal Substance Misuse on Children from Conception through Adulthood. And I am so delighted to be able to offer this training to all of you. It is a subject that is very near and dear to my heart, and I have spent most of my professional career working with some of these issues and many of these children. And I am also really delighted to say that the weather is much better today than it was when we did the training yesterday. And I certainly had a first in my training career, and that was that we were under 2 tornado warnings during the 4-hour training. So it was really pretty interesting. And I'm all glad we didn't get blown away to Kansas, and I hope that everyone stayed safe during the storm. So we do have a lot to cover today. I want to be able to give you as much information as I possibly can about this topic, because it is such an important topic for all of us to know about and learn about, and then to spread the word about, to raise awareness about these issues and some of the things that we can do to have a more positive outcome for children that are prenatally exposed. So we are going to jump right in with our learning objectives for today, and those are to describe the effects of substance use on fetal development and the postnatal period, to understand how substance misuse impacts attachment relationships and parenting, and identify some effective family interventions. And third, to recognize possible short and long-term developmental problems associated with prenatal substance exposure. So some of the general effects, overall effects of drugs or alcohol on fetal development, we do know that all drugs cross the placenta and can affect fetal brain development, resulting in lifelong effects in learning, in social relationships, in employment, and behavior. What we still don't know after all of these years, though, is exactly how that developmental timing and dosages and genetics affect these processes. So there's still a lot that we are learning about and trying to find out about. What we do know is that of all of the substances of abuse, and that is including cocaine and heroin and marijuana and meth, alcohol produces by far the most serious neurobehavioral effects in the fetus. And that was determined and announced by the Institute of Medicine in 1996 and stays true to this very day. And actually, of all those other drugs combined, alcohol has by far the most serious neurobehavioral effects in the fetus. And we're going to talk more about why that might be as we get further into our presentation today. We do not know specifically how each drug affects specific parts of the brain, although we do know that although the areas of the brain that appear to be the most impacted by all drugs, including alcohol, are those responsible for what we call executive functioning. And we're going to spend quite a bit of time talking about executive functioning and why that is so critical and so important to being able to lead a healthy and productive life. So in 2020, in a 2020 Morbidity and Mortality Weekly report article, the Centers for Disease Control, or CDC, scientists found that about 10% of pregnant women reported current alcohol use. And the use of other substances was common among pregnant women who reported alcohol use. About 40% reported current use of one or more other substances. And that is from a CDC report in 2020. And I can also say that from our experience at the clinic at the Florida Center for Early Childhood, where I worked for 20 years and started the state's only fetal alcohol diagnostic clinic in 2005, which is still going strong, I'm happy to say, that the majority of women who we saw, or the birth records that we were able to obtain, showed that there were at least 2 or 3 substances being used in addition to alcohol. Women tend to be polydrug users, unlike men. And so as the CDC found, it is not at all uncommon for women to be using alcohol in combination with 2 or 3 other drugs. We do know that drugs can alter fetal development through a very wide variety of mechanisms. And we also know that drugs can also directly impact and affect the uterus and or the placenta, the heart, the lungs, and the brain of the mother. So it is, drugs and alcohol are definitely dangerous things for women to be using in general, just period. But when pregnant, they are incredibly also detrimental to the fetus. So I wanted to show you this slide on fetal development because I think it's really important to understand how much the important growth that's taking place during this period of 9 months of fetal development. And what you can see, though, the dark blue lines is the period of time where the most impact can occur, a pretty high level of impact can occur, where major morphological abnormalities can occur in the fetus. And the light blue line is where more, maybe more minor abnormalities might occur. And I want you to pay attention to is on that very top line, what we have there is the CNS, and that's the central nervous system. And your central nervous system is your brain and your spinal cord. So you can see from this slide that first trimester, actually almost the first 16 weeks of conception, is when major abnormalities can occur to the brain of the fetus. But there is no safe time through that entire 38 week of gestation that the brain is safe from having any kind of impact. The brain is the most vulnerable organ throughout the entire time of pregnancy. And then as we go down that chart, you see the heart, the upper limbs, the eyes, the lower limbs, your teeth, your palate, your external genitalia, and then your ear. And I want you to look at the ear because I was actually very surprised the first time that I saw this slide, that there was such a long period of time, not as long as the brain, but the second longest period of time of any other organ, where major abnormality can occur during that first trimester. And what we do know is that the first trimester is the most dangerous time to be using alcohol and drugs. And that's also frightening because many women don't even know that they are pregnant sometimes until they are 8 or 10 or even 12 weeks pregnant or beyond that. So they could be using drugs and alcohol during this entire period of time, even heavily, and not be aware that they are even pregnant. There are also studies that show that women who have used alcohol heavily in this first trimester, then realized that they were pregnant and stopped using and did not drink during the rest of the pregnancy, still had a baby born with full-blown fetal alcohol syndrome. And that is because this first trimester is so important in terms of brain development and some of these other critical organs of development. And I'm going to go back to the ear for just a second, because the ear, we typically don't think of our ear as being that critically important, but the ear is actually very complex. We have an inner ear and an outer ear, and that inner ear is part of our vestibular system, a sense that most of us don't even realize that we have. So that can affect our balance. It can affect where our bodies feel they are in space. And also, maybe a high percentage of babies born with fetal alcohol exposure have congenital hearing defects. And then because their heads and their ear canals are typically smaller, they also can have hearing loss related to chronic ear infections. So again, just the importance of this slide and how to, really pay attention to making sure that women who are planning or working on conceiving also know the dangers of drinking alcohol or doing drugs during that early time while they're trying to conceive, because there's no alarm that goes off in our head that says, bing, you just conceived, now stop drinking and using drugs. It doesn't work that way. So, prevention is the very best thing, and information and education. So we're going to talk about what a teratogen is, and that's a word that I don't know how many of you have heard before, but it's an important word when we talk about this, because it's an agent that causes physical or developmental defects in an unborn child, birth defects. And the most common teratogens, not all drugs are teratogens. The most common teratogens are alcohol, mercury, isotretinoin, and that's the brand name is Accutane, and that's a treatment for severe acne, nicotine. So look at nicotine and alcohol, often used in combination by women and people in general, though both of those are teratogens. So both can cause birth defects. And then phenytoin, which is Dilantin, and that's a treatment for epilepsy. And that can actually result in fetal hydantoin syndrome, which is a syndrome that has similar facial features to fetal alcohol syndrome and some of the same characteristics, but is caused from Dilantin use during pregnancy rather than alcohol. So we do know that combining substances is very harmful to the fetus. The greater the amount of the drugs, the longer the frequency used during the pregnancy, the greater the risk to the unborn child. So there is like a dose-related response. The more a woman uses, the more frequently she uses, the more in combination she uses with drugs, the greater the risk is to the fetus. So the risks are significantly higher when mothers have used a combination of drugs during pregnancy. And sometimes those also include prescription drugs as well as illegal drugs. And then you can see here that a combination of smoking and drinking alcohol during pregnancy really add additionally high risk. And we know that from multiple research studies that have been repeated a number of times. So who is most at risk? Are there at-risk populations for this happening to? There are. And research indicates that the age groups of 18 to 34 with the highest birth rates are also the age groups most likely to use legal and illegal drugs. And that, in a sense would make sense because those are the childbearing years. And those also happens to be the time when women are most likely to use legal and illegal drugs. We also know that binge drinking, which is equal to about 5 drinks or more at a setting, can be very dangerous for the developing brain. And I found this fascinating, and it didn't shock me, but I found it fascinating that the highest risk group for binge drinking is women in their 30s with a college degree earning more than $50,000 a year. And that's sort of that social drinking group that hangs out, they might be frequenting bars or each other's homes, and it's social drinking, but it's binge drinking. And so that has now become the highest risk population. And we often tend to stereotype women who use substances during pregnancy or who binge drink. And we can't stereotype because every single person is susceptible and at risk. And as you can see from here, a highly educated woman in a high socioeconomic status is the highest group for binge drinking. What we do know, and this has been published by the Center for Disease Control, is that there is no safe amount of alcohol or drugs, and there is no safe time during the fetal period of development to be using. And that is because we just don't know on any given particular day in that fetal development how that's going to impact that particular fetus. And we know that every mother and every fetus metabolizes alcohol very differently. So I could have 5 drinks in one setting, and another woman my age could have the same kind of alcohol, 5 drinks in one setting. My baby might not be affected, whereas her baby might. So the risk level is just too high, and we say, why take the risk? So the message that we want out there from everyone in this field is there is no safe amount and there is no safe time during pregnancy to drink or to use drugs. And I find that frustrating because I still hear from women that their obstetricians are telling them that it's okay to have a glass of wine or 2 a day. It's not really going to hurt the baby, especially in the last trimester. And we really have got to dispel that message, because the message is there is no safe time, there is no safe amount, and it's not worth the risk. So some of the risk factors that can complicate the situation, again, is the dose of the alcohol or the dose of the drugs, the amount of that, the timing of moderate high usage during pregnancy. Again, remembering that first trimester is the most critical period of time where major abnormalities can occur to the brain, but also to other organs in the fetus's system. The pattern of exposure, binge drinking versus chronic drinking, the developmental timing of the exposure, the genetic variation, which we just kind of talked a little bit about, that every woman metabolizes alcohol differently. We know that women metabolize alcohol much slower than men do. That's why it is recommended that women, if they do drink, not drink more than 1 drink a day. And we know that every fetus metabolizes alcohol very differently. And we know this from fraternal twin studies, where there are 2 babies, 2 eggs, but the 2 eggs have been exposed, the 2 fetuses have been exposed to the same amount of alcohol in the same mother's womb with the same environment going on, but those 2 babies can have very different effects. We've seen, I've seen fraternal twins that I've evaluated where one twin had full-blown fetal alcohol syndrome and the other one had, I would say, more moderate effects, not the facial features. So that's why we know that's why we say no safe time, no safe amount, because you just don't know. You can't pinpoint the genetic variations of the fetuses or the mom. The synergistic reaction with other drugs is a risk factor. And interaction with nutritional variables is also very important. Women who have poor nutrition during their pregnancy are at higher risk of having infants that are going to have challenges when they are born. And because nutrition, the baby gets the nutrition, the fetus gets the nutrition from the mother. And if the mother is eating poorly and doesn't have a healthy diet, and often women who drink alcohol heavily or use drugs, they have poor nutrition, and many of them don't receive prenatal care. So that is another risk factor that we take into consideration. So exactly how do drugs and alcohol get from the pregnant woman into the fetus? Well, we know that the pregnant woman and the fetus and the newborn infant are at risk, as many of these drugs can easily cross the placenta and even go into the breast milk. And we used to believe that the placenta, that there was a blood-brain barrier there, that anything that was harmful that the mother did could not enter and transfer to the baby through the umbilical cord. We now know that's absolutely not true. And in fact, many of those drugs can transfer very, very quickly. We know that the alcohol level of a mother is exactly equal to the alcohol level in the fetus. So that shows you how rapidly the alcohol transfers through that umbilical cord and reaches the fetus. If the mother's blood alcohol is 1.2, the baby's blood alcohol level, the fetus's blood alcohol level is going to be a 1.2. And that's a huge problem. But one of the other problems is the mother can metabolize the alcohol faster if her liver is in good shape and functioning well. The baby, on the other hand, the fetus's liver is not developed. And so it takes a much longer time to break down that alcohol, so that blood alcohol level stays at a high level for a much longer period of time than the mother's might. So we know that the use of drugs and alcohol increases risk for mother and the fetus. And a pregnant woman's use of drugs or alcohol can increase the risk for a number of things that can happen in that pregnancy, including prenatal death, premature death, miscarriage, certainly birth defects, especially if there's high use in that first trimester. There is almost always low birth weight, small size for gestational age, neurobehavioral symptoms, which we will get into a lot more in the presentation, a smaller head circumference and sometimes microcephaly. And the head is small because the brain is small, because the brain is underdeveloped. And that has a significant impact on behavior and learning and all kinds of things that we need to be able to do to function as human beings. And a faster than normal heart rate. And that happens more frequently in babies who have been exposed to stimulants than to alcohol. Alcohol is a depressant, and babies exposed to alcohol can actually have a slower than normal heart rate, whereas babies exposed to cocaine, which is a stimulant, may again have a faster heart rate. So I'm going to spend some time, probably more time, talking about the effect of alcohol on brain development than some of the other drugs. And that is because of what we said earlier. It is the most damaging of all the other drugs combined to the unborn fetus. And it's important to me, this is a topic I've spent a lot of time learning about. I am an adoptive mom of a 32-year-old son with fetal alcohol syndrome. And we got him at the age of 4.5 months right out of Harlem Hospital, their NICU, where he had spent the first 4.5 months of his life. And this was in 1989 when the crack epidemic was taking place in New York City. And there were about 150 plus babies born a day in the city, in the various hospitals. that were either crack cocaine exposed, addicted, or tested positive to crack cocaine, or fetal alcohol exposed or fetal alcohol syndrome. And at that point in time, that was considered an automatic removal, a call into Child Protective Services and an automatic removal. And so when you think about those numbers, there was no way that they had enough foster parents or even kinship homes to place these babies into. And so there really was a crisis. There was an absolute crisis in the city. And DCF put out a notice, an invitation to agencies who were doing foster care within a 150-mile radius. And I was living in Albany, New York at the time and working for a Catholic nonprofit agency. And foster care was one of our programs. And so our CEO said, yes, we will do this. We will take these babies. It was actually called the Border Baby Program. And then she said, she was a nun, and she said, every employee will become a foster parent. So I don't know how you say no to a nun, but I wasn't able to do that. And I don't think any other employee did it either. And so I went home and told my husband and our 14-year-old daughter that we were going to become foster parents. This was, an expectation of employees at the agency. And my husband said, oh, I don't want to go through this again. And, our daughter's 14. We're almost into the empty nest syndrome. And I said, honey, it's fine. It's going to be fine because it's just foster care. It's short-term foster care. And we're going to help this baby's mom get, well and healthy and return the baby to her. So, 32 years later, he's ours, and we're grateful for that. So I'll never say it's only foster care. So we have lived with fetal alcohol syndrome with him for 32 years. He's been the best teacher I have ever had in my life. Continues to be the best teacher. I have learned so much from him about what works and what doesn't work. And so I've spent a lifetime since then pretty much devoted to this topic and to the exposure of other drugs as well. So in terms of alcohol and brain development, as the fetus develops, the cells that will become the brain and the nervous system, that central nervous system, will attach to each other. And this is a very, very rapid process. This happens very, 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 very quickly in fetal development. Well, alcohol actually interferes with this process of brain development, absolutely interferes and impacts it. And so that the outcome is that the baby's brain may be smaller. There might be structural damage, which we're going to take a look at what that might look like, or functional damage where you don't see the structural damage on an MRI, but there's functional impairment in how they behave, in how they relate, in how they learn, and all of that part of their life, which we can measure. We can tell that with through a neuropsychological evaluation when there's been functional brain damage. We know that there can be differences between the right and the left hemisphere. There can be abnormalities, and that's important because we need both our left and our right hemisphere really functioning very well and coordinated together. And it's that cerebral cortex at the center of the brain that helps transfer the information from the right to the left hemisphere and vice versa. And if that particular part of the brain is not functioning well, then everything else that the brain has to do is going to be impacted. And that can the result of that, you can see in how an individual functions. So this is just a slide showing the continuum of brain dysfunction from prenatal alcohol exposure. So what we have is the prenatal ethanol exposure. As a result of that, we have decreased neuron production, and that results in the small brain. We then have migration abnormalities. So cells that are supposed to migrate to certain parts of the brain may be absolutely disrupted and end up in a different part of the brain. And that can result in structural brain abnormalities. We can have neurotransmitter pathway disruptions, and where there's abnormal neurotransmitters, there's pathway activity, and that results in electrical dysfunction. And that results in modularity and how we modulate in our cognitive behavioral dysfunction. And that can lead to sensory impairments. And we're going to spend quite a bit of time talking about some of the sensory impairments that can occur. And that is not just true of alcohol. There are many children who were exposed to drugs who are also showing significant sensory impairments. And that affects learning and really how you socially function in society. And then from that, we have abnormal pruning. And that pruning process is really a very critical time in that brain development to keep the cells that we need and the neurons that we need, and then to prune what we don't need. And that results in a loss of IQ and central nervous system dysfunction, which is what we see in many of these individuals. That results in developmental delays, in learning disabilities, and in intellectual disabilities as well. And so the result of that, what we see in individuals then are impairments in memory, impairments in attention, impairments in what we call adaptive behavior, use of social rules, in sleep, and certainly in behavior regulation. And we're going to cover those in more detail. But most of the things that you see there, memory, attention, adaptive behavior, use of social rules, and behavior regulation, those are all critically important in executive functioning. So if you see that the greatest impairments are there, it would make sense then that we see that the greatest impairments are in the executive functioning of the brain. So I just wanted to show you this slide. This is the very first autopsied brain of a baby that was full term but stillborn with fetal alcohol syndrome. And that's that very tiny small brain that you see on the left side of your screen. And the brain on the right side is the normal brain of a full term baby that had no prenatal alcohol exposure. And this is the kind of structural abnormalities that we're talking about that can happen with significant exposure to alcohol prenatally. And what you'll notice is that there's not just structural abnormality in the size of the brain, although that is very significant, the difference in those brain sizes. But the other major difference is in this very rich, sort of spaghetti-shaped top part of the brain called the cerebral cortex. And that's the thinking part of your brain, and very much needed to be able to think and to plan and to function well in society. That cerebral cortex in that prenatally exposed baby is grossly underdeveloped. And also you can see the impairment in that center between the right and the left hemisphere. That corpus callosum is very malformed in the baby that's been prenatally exposed. And then this is just a slide showing you the brain structures that are most sensitive to prenatal alcohol exposure. And you can see the unaffected brain on the left side of the slide, and you can see the affected brain. And again, you see the difference in the brain size. You can see the difference in the corpus callosum size. And then you can see the difference in the cerebellum, and that's that blue area of the brain. It is smaller and it is not as well developed. And those functions, you can read on the side, the function of the corpus callosum is really to process sensory information, to help transfer that information from one hemisphere to the other hemisphere. And it can result in problems with all kinds of problems in retrieving information, in processing information, and the use of working memory. And the cerebellum is critically important for motor development. And you can see that when there's impairment in the cerebellum, you're going to see motor issues that might be occurring, coordination issues that might be occurring. And that is because the brain is not fully developed. There have been some slides of babies that have been heavily prenatally exposed to alcohol, where there is no corpus callosum at all, and we call that agenesis of the corpus callosum. And those individuals actually don't tend to survive for very long. And if they do, there is significant impairment that is just, you can't, it's permanent brain damage. There isn't anything that you can do about that. So of the impact of prenatal and fetal exposure to drugs or alcohol, it does appear that all or nearly all drugs impact the developing brain, causing what we call neurobehavioral effects in the fetus that can be lifelong. The effects can be physical, they can be emotional, they can be cognitive, they can be social, they can be behavioral, and usually what we see is a combination of all of the above. I don't think I've ever evaluated or seen an individual with prenatal exposure to drugs or alcohol that haven't had some impairment in at least one of these areas. And most frequently, there are two or three or a combination of all of the above. We know that opioids and polysubstance exposure research is showing that behavior and attention problems and lower cognitive functioning in 8-year-old children. And this is from a study that was done in 2016, but I have not seen anything that contradicts this in any more recent research than this, that we are seeing problems with attention and cognitive functioning in children who've been polysubstance exposed. And remember, women tend to be polysubstance users, and certainly then opioids. So what we are going to do now, we are going to have our very first activity, and that is a polling question. And the question is, which of the following substances is most likely to cause fetal harm? Heroin, methamphetamine, alcohol, or tobacco? So we're going to have our poll put out. And please respond, and then we will see our results in just a second. So if you have not yet voted, please vote, and then we'll see what the results of our polling turned out to be. All right, and here we are. 7% say heroin, 0% methamphetamine, 93% alcohol, and 0% tobacco. And you were very good listeners, because the answer certainly is alcohol. It causes by far the greatest harm to the unborn fetus. But remember, there's no safe time. And the more that you use alcohol and tobacco in combination, or any one of these other drugs, the higher the risk factor is. But yes, alcohol can cause the most damaging long-term effects in the fetus. So we're going to talk a little bit about some of the withdrawal symptoms that we can see in newborns. And these withdrawal symptoms can be from alcohol, from drugs, or a combination of any one of those kinds of mixtures. We almost always see tremors. And sometimes those tremors can be anywhere from mild to pretty severe. In Seth's birth chart, his birth records, which we were able to obtain, he had significant tremors, and he's 32 years old and he still has tremors. So that has been an effect that has not gone away over time, or even reduced. Even with medications, the tremors they really still are not under control. It's pretty amazing what he is able to do in terms of his fine motor control in building and cutting with scissors. And I watch him cut out these very intricate little buildings and people to make dioramas, which he loves to do. And his little shaky hands hold these scissors with the tremors still there. I could never do it in a million years. And he still maneuvers and cuts around all of these very intricate things. And sometimes he'll say, "Why did my hand shake, Mom?" And so we have a conversation about that. Sleeplessness is not just present in newborns. These individuals often have sleep issues for all of their lives. It's an issue in prenatal drug exposure, and it's an issue in prenatal alcohol exposure. But as infants in the newborn nurseries or in the NICU, they really don't have a sleep-wake pattern. There's no dependency on, this is going to be their nap time, so I can take a break. It's very unpredictable, and sometimes they don't sleep. There is a very high-pitched crying and a sense of agitation. And if you've never heard this cry, and Seth still had this cry even at 4.5 months when we got him from the NICU. When he cried, it was still a very sort of high-pitched, almost abnormal sort of a baby cry. And that faded away, in time, but this is very often very present at birth. They can have muscle spasms. Sometimes these muscle spasms have to be treated with medications because they're so severe. They can have seizures. Children who have been prenatally exposed to both alcohol and drugs are at high risk of seizures, and feeding difficulties. And that can come from the fact that they are so restless and agitated that it's hard for them to even focus on being fed. But also it can come from low muscle tone, which can happen in children prenatally exposed to alcohol. They tend to be hypotonic or low tone, and babies exposed to stimulants tend to be hypertonic or very high tone. So if they're low tone, their suck reflex is going to be poor. And so it's going to be a much more difficult time feeding them, and they have a much slower time gaining weight. When we got Seth out of the NICU at 4.5 months, he weighed 8 pounds. He was born at 5.3 pounds, but very slow time gaining weight, and that's partly because of the fetal alcohol syndrome. Also in part because he had a cleft palate of the soft palate. And remember that developmental line for the palate, that was a pretty big line. So they can have soft palate, hard palate, or a combination of the two. So let's just talk a minute about the benefits of breastfeeding while taking methadone. Moms who are addicted to opioids and are trying to wean off of those opioids or meth or methamphetamine sometimes will be on a methadone assisted treatment program. And they need that because they're at high risk if they stop using or taking the opioids at all. They're actually can be at risk of death, or their fetuses can be at risk of death. So many of our moms that we see in the program are on methadone treatment. There has been controversy in the past years about whether this is a good thing to breastfeed when moms are taking methadone or not. The benefits of breastfeeding are that the baby receives all the benefits of breast milk. And we know from the vast research that has been done that breast milk is so much better than formula milk. It builds up the immune system better. Babies tend to gain weight faster on breast milk. And one big thing is that it enhances maternal-infant bonding. And that is so critically important for these moms who have used substances during their pregnancy and are suffering from a tremendous amount of guilt because they can visually see the impact and the distress that their newborn is going through. And it's painful for them. And it makes them feel very bad about themselves. So one of the things that can help with that is we can say, Mom, you have so much to offer your baby right now. Let's get you breastfeeding your baby. And so that makes mom feel better about being a mom. The baby's getting the breast milk, but the baby is also getting that very, very vital skin-to-skin contact. And we know that skin-to-skin touch really has a direct impact on the brain and how the brain is functioning and how the brain develops. Touch is critically important. It's one of our most important senses in terms of how our brains function. And so that skin-to-skin contact is just so important. And often the eye contact comes with breastfeeding, and that's how they relate to one another. Eye contact is one of the first, eye contact and touch are the two first mechanisms of communicating and of the attachment process. So all of those wonderful things can be taking place when a mom is breastfeeding her child. And it is safe to breast or chest feed while taking medications for opioid use disorder, such as methadone and buprenorphine, regardless of the dose of the medication that you take. And you can consult the LACMed database to learn more about the evidence on use of the medications while lactating, and that's methadone, buprenorphine, and naloxone. So breast or chest feeding can make the baby's withdrawal symptoms less severe. And we are learning this. This is new information and new research that's coming out every single day. Studies now suggest that this is because of that skin-to-skin contact we just talked about, and that attachment formation help the baby feel better while breast and chest feeding. It actually soothes the baby and helps them out of this state of agitation and restlessness. And when other opioids like methadone were studied, it was found that only about 2% of the total dose made it into the human milk. For buprenorphine, there were really negligible amounts of that or no buprenorphine nor buprenorphine in human milk. And infants absorb even less of this because of the way that the buprenorphine is broken down and metabolized. It's not absorbed well into the stomach. And so we really have to dispel this myth, I think, that's been around for quite a long time. And that is if the mom is using methadone and breastfeeding, the baby's gonna, be a drug addict and get opioids. Research is finding that if it is, it's extremely minimal and not harmful to the baby, and actually very beneficial for both the baby and the mother and the attachment process. There are some cautions of breastfeeding while taking methadone. With heroin and other unregulated opioids, it is best not to breast or chest feed, since you can't really know the exact dose and it may be cut, and this is the big risk. It may be cut with other unknown substances like fentanyl, and contaminants that are not safe for the baby, and in fact can be lethal for the baby. And if mom is using street drugs, we do not know how much of that heroin has been cut with, and we were seeing a tremendous amount when we were going through a lot of the opioid issues here in our community, high amounts of fentanyl overdoses that were occurring because of the mix of the drugs being combined together. Most drugs a mother takes are present in her breast milk in a small amount. And there can be some safety risk for the infant when mom is falling asleep or not fully functional while nursing. And we have a Healthy Families program at the Florida Center for Early Childhood. And one of the things that our Healthy Families workers were reporting is that sometimes they were going into the home and mom was nursing and doing a great job nursing. But even in the course of the conversation with the Healthy Families worker was falling asleep. And one family support worker actually had to catch the baby from falling onto the floor. So making sure that the provider of the methadone is aware that mom is getting drowsy or falling asleep, and that can create all kinds of risk for the infant. The sleep issues of falling over on the baby, or the baby falling, or mom just not being they're available physically and emotionally available for the infant. So that's just a word of caution. And then we're just going to talk about neonatal abstinence syndrome for just a second. If I can get my little clicker to cooperate. There we go. So we've heard a lot about NAS in the past 7 to 8 years because of the opioid epidemic. And Florida has really been an epicenter of the opioid epidemic. And here in Sarasota and Manatee counties, we have had, this has been a major issue that's been impacting our community. And neonatal abstinence syndrome can occur within 24 hours to 5 days after birth and is related to those physiological withdrawal from any opioid. And that's from heroin, that's from fentanyl, or treatments like buprenorphine and methadone. It is treatable with skin-to-skin contact, so we can't overemphasize the need for that skin-to-skin contact. Keeping the parent in the same hospital room as the infant, breast or chest feeding, or also with medications such as methadone, sometimes morphine, buprenorphine, or other agents as needed to help the baby through some of these NAS withdrawal symptoms that they're experiencing. Sometimes they can go on for a bit of a prolonged period of time, and that then creates a situation where the baby is in the NICU for maybe, quite a while, weaning from the drugs and getting under control in terms of the withdrawal. And that is a time when we have got to, and we'll talk more about this later, but a time when we have got to really pay very special attention to the bonding and attachment process. If that baby's in the NICU, for 3 or 4 or even 2 months, that is a critical period of time in that first year of life for bonding and attachment to occur, both for the mom to attach to the baby, but also for the baby to attach to the mom. So making sure, again, that we are changing our protocols of this, baby's kept away from mom in the NICU on all these machines, and mom doesn't have an opportunity to see, to touch, to feel, to hear, or to be a vital treatment protocol for her baby, which then also can add to her sense of guilt and remorse and shame and all of those things that we do not want her to feel. She's got enough of that on her own self that the system does not need to be putting that on her as well. So we've learned a lot through all of this opioid epidemic crisis, and we've learned sort of what works and what doesn't work best for mom and baby. And hopefully every hospital is beginning to change or has changed their policies around that. So we are at a point where we are going to take our first, coming right up on 2 o'clock, we're going to take our first 15-minute break, and then we are going to resume, and we still have a lot to cover. So if my IT wonderful team can put up our break slide, it is 2 o'clock, and so we will be back here at 2:15. I want you to get up and stretch and get something to drink, because sitting on Zoom for 4 hours is challenging, and your muscles begin to ache and you begin to get dehydrated. So move, do some jumping jacks and get some liquid, and we'll be back in 15 minutes. Well, welcome back, everyone. I hope you had a lovely short break and that you got something to drink and that you were able to stretch yourselves a little bit. And we are going to pick up and keep going. And the next part of our presentation is going to be about how substance use affects the mother-infant attachment. And this is something this is an area of my professional career that's been very, very important to me. I am an infant mental health therapist by profession, and that has been the majority of my work in my professional career, all of my life. And I just feel that there is so much more that we can be doing as multiple systems working with moms and babies who have been impacted by substance use to help in that attachment. And to not automatically assume that because this mom is using substances that she's not capable of attaching to her baby or of being a good mother, because we know that that is really not true. She has the capacity with a lot of supports and a lot of wraparound services. We have seen incredible outcomes for these moms and babies. So this is just a slide showing you the neurobiological impact of addiction on maternal functioning and the mother-infant dyad. And I think I'm a visual person, so I love this slide. So what you can see up here in the left-hand corner is that mom has her own genetic factors that she's dealing with. She has her own developmental history, and we have no idea what that might be. We have environment, we have stressors, we have psychiatric disorders frequently, and certainly trauma histories. And in the work that we've done at the Florida Center over the years, and I was there for 20 years, and in both in practice and as in an administrative supervisory capacity, and then as the CEO, we see many of these moms and babies in the clinic, or we have their birth history, and there is often a history of trauma in the mothers. Sometimes horrendous trauma in the mothers. And so when all of those factors are combined for an individual, it can result in the chronic use of drugs. And if there is a chronic use of drugs, what we can see are brain adaptations in different circuits of the brain. And that can be in the reward, the motivation, the inhibitory control, which is extremely important, and then in that area of executive functioning, which we talked about. And that can result in loss of control over the drug intake, and that can often lead to overdoses and just chronic use of drugs without being able to have any control over them. Compulsive drug seeking because they're so desperately in need of the drug. Poor decision-making because their executive functioning is not working. And then withdrawal or tolerance of the drug and of just really life in general. And those problems can lead to maternal self-regulatory problems, to dyadic regulatory problems, and we're going to talk about what that looks like, to maladaptive maternal responses where they're just not responding to their baby in ways that are healthy and functional, definitely to attachment difficulties, and also to infant developmental concerns. So there's a lot that gets packed into this slide, from what the mom has experienced in her lifetime, how that's sort of turned into this chronic use of drugs, and then the result of that both in herself and in her relationship with her baby. So we'll talk first about how substance use affects the mother-infant attachment from the parent part. We know that addiction is associated to a dysregulation of the balance between the reward and stress neurobiological systems, which both undergo significant changes during the transition to parenthood. And we know that this balance between reward and stress is very brain-based. It is a neurobiological system, and it's impaired. And frequently the reward system is impaired, so that the mom is not really receiving the benefits of the reward that the baby might be eliciting, or the cues that the baby might be eliciting that would be normally or typically received as a reward response. So the drug use can affect these neurocircuits and do what we call hijack the same reward processing systems in the brain, making mothers less responsive to more natural cues, such as their infants' behaviors and facial expressions. So, and this is that dance we're going to talk about, that dance between mother and baby. And one of the things that happens, and it's coming from the brain, is that when your baby smiles at you or coos, that triggers the reward system in the mother's brain to continue this sort of interaction with this baby. It's reinforcing. And when that's not there, the mom's not getting the reward in her brain from the baby stimulus and the smiles and the coos and those kind of welcoming expressions. Also, if the mom did not have a secure attachment with a primary caregiver as a child, she may not have what we call in the infant mental health world, the internal working model within her to create that for her baby. And then, so thus the cycle sort of repeats itself. And that internal working model is critically important, because that's what we can relate to when we have a baby, and whether we're a first-time mom or whatever, it's that internal working model that we very unconsciously draw upon. It's how we were treated, how we see our own mothers in our minds and carry that forth in our mothering. And if that's not there at all, or if that's very abusive, that's not going to be created for that mom. So she's kind of working from scratch, in a sense, as to how to try to figure this out. And without assistance from a therapist, a child parent psychotherapist, or someone to really help her understand what's missing for her and how we have to rebuild her own internal working model, it becomes very, very challenging. So from the baby's part, we know that nearly all drugs affect the neurobehavioral systems of the baby's brain, sometimes for a lifetime, and that many of these infants exhibit symptoms of a regulatory disorder, and that is a diagnostic classification in the DC 0 to 5 is regulatory disorder. And I would say it's the primary diagnosis for most of these infants exposed to alcohol and drugs. They just have great difficulty regulating their sensory systems. And this can include dysfunction in autonomic regulation, that's that sleep-wake cycle, motor attentional interaction, and those self-regulatory systems that we typically just naturally, that's part of our developmental process. And if we're not impacted or haven't been affected by drugs or alcohol, that will just normally, those processes will normally develop. But dysregulation in any one or more of these domains may interfere with basic neonatal functions such as feeding. We talked about the stresses of feeding, sleeping. Again, that's a major thing that parents are reporting, both birth parents and foster parents and adoptive parents. And it is often a primary reason for foster care placement failure of these infants and young children, is because they don't sleep. And many of our foster parents have, 2 or 3 or 4 or more of these kiddos that have been prenatally affected. It's the number one reason kids are coming into care across the country is parental substance use. And so if these kiddos, are not sleeping during the night, and there is no in-house respite, night respite for foster parents, which absolutely, positively has got to be created. And I speak that as a former foster mom, an adoptive mom. You need that nighttime. You need your sleep to be fully functional and emotionally in control, and that's extremely important. And so we need nighttime nannies that can go into the home and be there to assist that baby during the night, or that young child during the night when they are awake and they're not sleeping, so that the foster parents can get some sleep. And then growth. And we talked about that. There is almost always pre and postnatal growth deficiency in fetal alcohol syndrome in particular. But because of their dysregulation in eating, growth can either be, they can either hoard, almost like hoard food, like overeat, because that basic regulatory system at the base of their brain, and that's the first system that develops in the brain, it's not working. So there's not that trigger that says, oh, I'm full, I can stop eating now. It's malfunctioning. So many of these kids just keep eating and eating and eating until they really become obese. Or the system doesn't say I'm hungry, and so they don't feel hungry. And those kiddos have a very hard time gaining weight and keeping weight and eating. And some of them are extremely picky eaters and eat very few or tolerate very few foods and have difficulty gaining weight. Certainly emotional regulation. Their emotions can be all over the map, and typically are, both for children prenatally exposed to drugs and to alcohol and to the combinations. There can be attachment issues that's biologically brain-based. And as a mental health therapist, it's frustrating to me to see kids come into the program for mental health treatment, and many of them in foster care, with the diagnosis of RAD, reactive attachment disorder, which is a very specific disorder with a very specific cause. And what we have to understand is that many of these kiddos that have been prenatally exposed have attachment problems, have attachment issues that are brain-based because of all of the other issues that are taking place. So what would be their typical attachment responses in typical development are dysregulated. They aren't working in the capacity in the way that they should be. And then certainly dysregulation in social interaction, because if you are having issues with your behavior, if you're having issues in how you socially relate, if you're having issues in sleeping, it is going to impact how you get along with adults, how you get along with peers if you're in a preschool or a school setting. It's going to absolutely have an impact on your social interactions. There's just no other way around that. And then the impact of prenatal exposure of drugs or alcohol on the dyad part. And again, that separation of infant from the mother during withdrawal periods impacts attachment and bonding. So if the mom is in and out of treatment programs, especially residential programs, that's going to create separation that can have some impact. Certainly that neonatal period of time, if they are in the NICU for any prolonged period of time. Babies coming into foster care, if they're coming into foster care right from the hospital, or they're removed from their moms shortly after birth or during that first year of life, then that's going to have an impact on attachment. And one of the great things that we have here in Sarasota County, in Circuit 12 actually, in that Sarasota, Manatee, and DeSoto counties, is what we call early childhood court. And I don't know if you have those in your area, but you should see they're now in 27 circuits in the state of Florida. And this is a fantastic model. It's a problem-solving court. It is modeled after the National Organization 0 to 3's program called the Safe Babies Court Team, which has been around for 15 years or longer, operating in multiple sites around the country. They've had 2 independent evaluations done with the same consistent positive findings of positive results for the mom, for the baby, and for the dyad. And so we're very fortunate to have one here in Sarasota County. And so we work very hard from the moment if that baby is removed at the time while in the hospital or shortly after removal, and we can move in as long as the child is birth to 5 and begin this early childhood court immediately for her. And that allows the mom and the baby to have interaction and time together 3 to 4 times a week minimum. That's a requirement. And that's a lot of visitation time, and that's really high quality visitation time. And it's sort of coached visitation. So mom is learning about her baby and baby's learning about mom. And sometimes if this can't be in person, it's done through a Zoom, which can be very effective. And or mom on the phone with the baby hearing her on speaker being read a story to. And so the baby at least is hearing the mother's voice, and voice, mother's voice is a part of that attachment process. And remember that baby's been hearing the mother's voice for 9 months in utero. They can hear in utero. And so the baby's, that's not a foreign voice to the baby. That baby knows that mom's voice. So we can at least, even if it's through a phone call, maintain that contact and keep mom connected to the baby. So early childhood court is phenomenal. And the intent of that court is, if these babies have been removed, is the primary permanency goal is reunification. So every team, every mom and baby and dad, hopefully if there's a dad or a partner that's involved, we move in very quickly upon removal within a matter of days. And every dyad is assigned a licensed child parent psychotherapist, a case manager that's hired by our agencies, and it's a case manager that's very well trained in infant mental health and early childhood development. And they act as a very tight team in support of that mom and that baby. They are before the judge every 30 days, once a month instead of every 3 months. And that is huge. I mean, huge. Our judges have been trained in infant mental health. They've been trained in substance exposed newborns. They know what they're looking for. They know how to practice the whole very different model of doing early childhood court from the judge's perspective, which is very, very different. It's a very supportive and non-judgmental model from the bench. And so what we're seeing is a much faster return to the parent, and that's in every study that's been done and in the data that we're getting from around the state from the 27 circuits as well. There is a much improved child welfare, child well-being, and dyadic attachment well-being because they stay connected to the therapist. And even after they go home, the role of the therapist continues, providing the infant mental health, so that there's not a breach in the relationship that's been formed and the work that's been done. It will continue. And the other thing is that there's been a much lower return to care, which is what we want to see, because we don't want to see these babies continually removed and continually removed and continually removed and then going back and removed again. That is not productive for the baby's attachment process or the mom's attachment process. Those disruptions are really very harmful for this attachment process. So making sure that we have this dyad strong enough so that when the baby goes home with the mom, it's going to be successful. And making sure that we keep all of those services and supports and systems in place so that she does not fall through the cracks. And one of the things that I love about this court is that if mom has a relapse, and we all know that that happens, these are stressful babies who have been impacted. These are stressful moms who are trying to stay in recovery and sober and clean. And that is huge. I mean, that's huge. And just stressors alone, especially if the mom does not have a lot of supports around her, the risk for relapse is very high. It used to be, and I think in many places it still is, if the child is returned home and mom has a relapse, the baby goes back into care. We have to understand that relapse is a part of recovery. It is a part of recovery. And it is not unusual for women to relapse several times before they're able to really work it through to a full recovery process and stay there. So rather than yanking these babies again from the home, if mom relapses, unless she's, going into a residential treatment program, and then we try to have a family member step up to the plate and take the child, then we keep this baby with the mom, we work with the mom, we make sure that even in the care planning meetings and the family team meetings that take place, mom has a safety plan that if she feels like she's going to use again, she has 3 numbers of people that she can contact day or night. If she does relapse, it used to be that they wouldn't tell us because they were afraid we would take the child. But now they are telling us, they're saying, you know what, I used, you're going to see it on my drug screen. You're going to know I did relapse, I used, I only did it once, I'm back in my program, and supporting them through that process. And it's a whole way of doing business. And it's a much more compassionate way of doing business rather than being judgmental and critical and harming this very sensitive and very important bonding process that needs to happen for mom and baby. We know that guilt and substance use abuse and mental health issues, including trauma, and most especially trauma, impact attachment and bonding. And then again, these infant issues of poor sleep patterns and difficulty feeding, and this fussy, irritable temperament and prolonged crying and poor eye contact, and difficult to soothe and over and under reactive to stimuli can absolutely positively impact the attachment and the bonding process. And that's why it is so important for this child parent psychotherapist to be involved in the treatment that's taking place. So mom understands where all of these babies' behaviors are coming from. Otherwise, they feel that the baby is rejecting them, that they're terrible moms, that nothing that they're doing is really working to soothe the baby. It's helping them to understand this is part of what we see in this as some of the effects, and then helping them with strategies to help them learn their baby's cues and how they might be able to soothe them better. And that's trial and error. And I say that from experience. And I was an infant mental health therapist when we got Seth. And I tried every trick in the book to calm and soothe him and failed miserably a great deal of the time. And there was a point in time, I think, when I began to personalize it and to say, I must be doing, something wrong here because everything I'm doing is really not working. And then, I'd have to remind myself, no, this is a part of what he's going through. And it's not about me. I know I'm a good mom. I raised one very healthy child to the age of 14, and really needing that reassuring myself that why this was occurring. So attachment is a two-way street. Each individual, it's a relationship. It's not unlike a relationship between a husband and a wife or partners or whatever. Each individual must be able to read the other individual's cues, and each individual must be able to respond appropriately to those cues. And I keep advancing these slides, and I don't mean to. And that's important. If you can't sort of have this response back and forth, it's hard to have a relationship that's secure and meaningful to you. And when an infant's neurobehavioral functioning is disrupted by the effects of prenatal drug and alcohol exposure, the infant may not be able to participate in this give and take dynamic that's required for attachment to occur. Excuse me. And and what we see then is that this, what we call serve and return, this sort of dance that goes on between the mother and the baby, really does not flow well. And there's a wonderful video called the Still Face video. If you have not seen it, I highly recommend looking at it. And you can Google that. And it's a research study that was done quite a while ago, but it's been repeated a number of times, and the outcomes are always the same. And this is a researcher who takes a normal, typical functioning mom with no issues whatsoever, and her infant, and with no issues whatsoever, typically developing infant, and they're put into a room. And the mom, the baby's like in a little carrier in front of the mom. And the mom is told to, engage with the baby like you would at home. How do you engage with your baby? And it's all that, that parentese that we talk about, like, you're so sweet, you're so pretty, you're so cute, I love you so much. And the baby responds with these amazing reactions of smiles and big eyes and eye contact, and the body can even get involved because they're so joyful in this interaction. And then that's the return. So then mom serves again and gets this wonderful response return back from the baby, and this very wonderful dance between the two of them continues. And building on that dance is what builds on attachment. And so that goes on for a couple of minutes. And then the researcher tells the mother to completely turn around and not face the baby and not engage. So the mom turns around, doesn't look at the baby, doesn't respond to the baby in any way, shape, or form. And that baby goes into significant distress and does everything to try to get the mother's re-engagement back, starting with, just making kind of silly noises and maybe laughing or giggling or cooing, and mom doesn't come back. And so then the baby escalates in their response. They'll start to cry, sometimes shriek or yell, or they'll begin to move and flail their bodies all over and become incredibly, incredibly distressed. And then the researcher tells the mom to return again, to re-engage with the baby, and have that process resume. It is a little bit painful to watch because you're like, oh my God, don't make the baby stress out that long. But healthy attachment relationships, what happens is the baby recovers very quickly. Not immediately. There's still kind of like, what is going on here? And they're kind of weighing in and waiting. But within about 30 seconds or so, they're right back where they started from. And so that process re-engages quickly. And that's how we know that that's a very healthy attachment that's occurring in that mom and baby. But think about that for a second. If that level of distress occurs in that baby when mom has turned her attention away for, it seems like an eternity, but honestly, it's not more than a minute, I don't think, at the most. think about what happens in these situations where mom's emotionally not available and maybe even physically not available to attend to the baby's needs. That baby will eventually just either really act out or completely and totally shut down and withdraw. And so making sure that this attachment process is healthy, ongoing, and takes place continuously, and that mom gets the kind of reinforcement that she needs in this. So when the caregiver does not receive positive feedback and reinforcement from the infant, then she may back off. And then again, this dance of attunement is disrupted and resulting in stress for both the mother and the infant then increases. And I've seen this so many times in my professional career when I was actually doing child-parent psychotherapy with prenatally exposed babies and moms that were in recovery and had been clean for a while. But the baby was, the babies don't recover quite as quickly. And from some of their effects. And remember, I said some of these effects can be lifelong. So it's really about mom beginning to understand, to not take it personally, and to learn how different strategies to learn how to deal with it. But I have had moms in sessions that have said to me, my baby hates me. My baby hated me the moment I conceived it. I actually had a mother say that about her daughter, who I think then was about 13 months old or so. And this 13-month-old was acting out all over the place, really having some significant issues as a result of prenatal exposure, but compounded by mom's inability or incapacity to relate to her in any kind of a positive way, and actually, really sort of relating to her in a negative way, seeing it as rejection, saying my baby has hated me since the moment of conception. I mean, that's pretty drastic. And that's going to take a while to work through all of that process. And a lot of the working in child-parent psychotherapy is with the moms and their own working models of themselves, and them working through what they have gone through and seeing how their experiences is impacting their parenting relationship with their own children. In child-parent psychotherapy, the client is not the child, and the client is not the parent. The client is the dyad. So this is just sort of a visual of the impact on infant-parent relationship. We have moms with significant, sometimes very significant behavioral health needs. Plus we have these babies in withdrawal with compromised brains. And I say compromised brains because, even if it's been not a prolonged period of time they've been exposed prenatally, or in high doses, remember that brain is vulnerable throughout the entire prenatal period. So there may in some way be some compromised brain that's taking place there. When these two things are going on, it absolutely has an impact on the infant and parent relationship. It places these dyads and moms and babies, the babies at very high risk for abuse and for neglect and for future problems. And so what we see is this cycle that we see way too many times, this vicious cycle of this dysregulated infant, mom's negative response, or even mom's positive response, but the baby can't handle it because maybe it's too overstimulating for the baby. So the baby has a negative response, which increases the mother's stress, making her feel rejected and inadequate. That certainly increases her risk for relapse and abuse to the child. And then both mom and infant disengage, and secure attachment is at risk. And then this, which makes the infant more dysregulated. And so this cycle just continues to go on. And my pledge to myself in this lifetime is that I am here so much to break these cycles, And I know that it can happen with the right interventions and the right treatments and the right supports. I've seen it way too many times, way too many success stories to say it's not possible. And it is possible with all of the right interventions and supports and services in place. If we're going to change our society and make it a healthy society, much healthier than it is today, we've got to break these cycles of abuse and neglect and trauma and substance use and mental health issues to the degree that we can do that. And then to this next generation of babies being born and growing up with the same issues we all know this is multi-generational. I have treated parents now who have children who I had as children in therapy. And we've all seen that. I mean, we've watched, children come through the child welfare system, and we saw their parents in the child welfare system. And so a sincere commitment to doing everything we possibly can to breaking these sort of vicious cycles of just, maladaptive functioning and social functioning. So just a slide on organic versus environmental, and these are related to the social detriments of health and recovery capital. We know that there are many factors that can impact fetal development when mothers have OUD, and those are the social determinants of health. And this is just a slide showing the factors that may exert programming effects on the developing fetus exposed to opioids in utero. And this is from a 2018 study. And what we see here are in the center of this circle is what's transpired with mom. Higher adverse childhood experiences, maternal emotion dysregulation, maternal trauma history, maternal psychopathology, maternal nutrition, which we talked about is really, really important, maternal neuroendocrine and parasympathetic responses to stress. If you're in this situation, you tend to have very high stress levels and overreactive stress, very high cortisol levels. And we have seen that with those high cortisol levels in the mother, babies are born with very high cortisol levels. Remember, there is no blood-brain barrier when we talk about those kinds of things. And then if mom and baby are in this situation where there is exposure to neighborhood violence, availability of opioids, and we know that they are still way too available, even though the shutting down of the pill mills has certainly helped to control some of those street substances, they're still available. And then decreased access and compliance with the healthcare system. Many of these women don't want to go in for prenatal care because they're afraid that if they report that they're using and they're pregnant, their babies are going to be removed from them right at birth, so they don't go. Or if they're using and the babies are home with them, they may not go in for regular routine healthcare checks because, again, they're afraid that their babies may get removed from them. And then poor parental care because they're not taking care of their own health needs. And then we have maternal social support is often lacking. Their socioeconomic status may be a factor. And then maternal partner substance use, and that's huge. If the partners, if I've seen this so many times, it saddens me. Moms get clean and they are committed to their sobriety and they are working really, really hard to stay clean. And then the partner comes into the house and gives her opioids. And she uses because she's addicted and she'll be addicted. Addiction is a lifetime disease. And if she's given it and if she's like really prompted sometimes to take that, she's going to use. If dads are going to be involved in this picture or partners are going to be involved in this picture, they need to be a part of the solution. They need to be a support to mom. They need to stay clean. They need to support mom being clean. They need to be involved in early childhood court if they're going to be a player in the scene. and they need to be involved in child parent psychotherapy or child parenting classes. If they're going to be involved in the picture, they need to be involved in the picture 100%. So I want to talk about, I've talked about child parent psychotherapy. I haven't gone into that in great detail, but please, there's so much literature on that. And fortunately, we've had a very strong training base in the state of Florida, thanks to FSU and the Center for Prevention and Early Intervention, who has funded these training programs for child parent psychotherapy. It's a 2-year process to become certified in child parent psychotherapy. It's a very specialized kind of therapy. Just because you're a mental health clinician doesn't mean you know how to do child parent psychotherapy. It's a very skilled and certified training process. So the other one that is also a pretty long training process is your certification in doing Circle of Security. And Circle of Security is the COS parenting program, which is what many of us are using across the state within our early childhood courts. The goals of that program are to increase security of attachment of the child to the parent, to increase the parent's ability to read the child's cues. Remember, we talked about how important it is for mom to be able to read the baby's cues, to increase the empathy in the parent for the child, for the parent not to be critical and blaming and scolding and punitive to the child for the behaviors that they're showing, but to help mom and dad increase their empathy for this child and what they're going through, to sort of walk in the child's shoes, if you will. And then to decrease negative attributions of the parent regarding the child's motivations. Just like what I said, that, this mom was perceiving that her baby hated her from the moment of conception, really changing and reframing the parents' negative attributions toward the children and why they're doing what they're doing is really very, very important. But I have found that once you talk to parents about that and you bring that to them with a different reframe and a different level of understanding, they get it and they begin to show more empathy. And we use a practice in child parent psychotherapy called talking for baby. It's a technique. And we do that as a therapist. If the baby's looking at mom and, maybe trying to say something, we'll talk for the baby and say, Mommy, I really need you to pick me up right now and hold me because I'm not feeling safe. Well, in the course of the treatment, mom learns to talk for baby. And the therapist will say, what do you think the baby's trying to tell you right now? We know things are changing and progressing when mom changes from the baby is telling me she doesn't want to be around me to, oh, she's just telling me that she's really happy that I'm here right now and I'm close to her. And that she loves me. I mean, that's like major, wonderful steps forward. So this is just a wonderful visual of Circle of Security. And we tell our parents to put this on, we laminate for this for them. We tell them to put it on the refrigerator, to have it during times of visitation. We tell the foster parents to put this on their refrigerator so that they can relate back to it. They've got to be the baby's hands too, as well. And what you see here are the adult hands, the parents' hands down here, holding the baby. And that is what we're doing. We're holding the baby. And we are remembering to be bigger and stronger and wiser and more loving in order to meet their needs. We try to remember to always follow the baby's cues first and only intervene when we need to intervene when things are not safe. So what you'll see in this diagram is if we are raising secure little people, they will feel secure in the hands of their caregivers, their parents, their foster parents, whoever is with them. The more secure they feel, the more likely they are then to begin to feel like it's okay to explore the world. I feel safe here. The world must be a safe place for me to be. So you begin to see them at young ages, sometimes before they can crawl, they'll scoot and they'll begin to scoot away from that primary caregiver, and maybe get a couple of feet out, and then they always turn and they check back to see where you are, or they may actually come back to touch you, to be with you. And if all is well in their world, they'll venture out some more. And as they get into that toddlerhood, these are kiddos that can venture off and explore the playground. But they almost always, through the first 3 years of life, and most especially the first 2, they will come back to you. It's great to watch videos of this, to just touch base, to touch base with your secure base again. Then they are okay in the world. They feel safe in the world. You are meeting their needs in the world. And then they are able to grow and to develop and to become a person who is very secure in the world. And we all need to feel security in our world. We need to feel security in ourselves. We need to feel security in our relationships with others. And we need to feel security in the world. And right now, that's a kind of challenging thing that's occurring for all of us. With COVID that's been going on, it's put a great deal of additional stress on our families and on our children and on all of us. I mean, even if we, have a great deal of security in who we are and our relationships, going out into the world right now, it can feel pretty insecure and unsafe. So we're all kind of, I know that for us, we're needing to be home more. We are not sort of venturing off, we're travelers, we love to travel, but we're not sort of venturing off into all this wild traveling like we really love to do, because our sense of security is our home base. And so even as adults, we never stop needing that sense of security in our world. Our little ones need that most especially. And we focus a lot. This is usually a group education program for parents, but we also use it individually for parents who might not be ready for a group setting yet in our child parent psychotherapy sessions. It can be taught individually. And I am so happy now that Circle of Security, I think it was last year or the year before, they have now come out with a program of Circles of Security for preschool classrooms. So preschool teachers are getting trained in Circle of Security. And so now we've got that strong base of that security platform working from our preschool settings and our home settings and our foster home settings. So it's a wonderful model, and we got to get it out to everybody. All right. We are now going to do our second activity, and this is going to be a small breakout discussion on parent-child attachment. And my IT friends are going to break you out into breakout groups. And what I want you to do is to select a spokesperson that's going to report out on your group's thoughts. And I want you to think of 3 possible strategies that could support parent-child attachment. And from a systems perspective, what are the main barriers in supporting parent-child attachment? So that's your assignment. We are going to take 15 minutes for this activity, and then we will return and we will have each of the breakout groups report back. I have 3:05 on my clock. So at 3:25, you will return back and we will report out and see what everybody had to say about this. So IT friends, help us get into breakout groups. Well, welcome back from your breakout sessions. I hope you had a lively discussion. And I did learn from our IT group that we had 12 breakout sessions and they were all full. So we've got a lot of folks on our workshop today, which is great. So right now we're going to very quickly report out as groups and hear what everybody else had to say. And if you get down to be like one of the last of the groups and everybody's been said, just add what, if you have anything differently that you would like to add to the list of possible strategies or some of the barriers from a systems perspective. So we will hear from the reporter in breakout room number 1. So just unmute yourself and please report out quickly and then remute yourself. Breakout 1.
I think that's me.
Okay.
Okay. So although we had a breakout room, actually, we only had like 4 people show up out of the 7 or 3 people actually, besides myself, interacting. So, but we did good. We came up with 3 strategies were breastfeeding, using play therapy or TheraPlay, and infant massage. And some of the barriers were lack of services and resources. It would be ideal if there was a live-in foster home for the mother and baby to get parenting skills. Language barriers, significant distance between the mother and the infant, so the mother can't travel to get to see infant. COVID-19 restrictions or even coming down with it. No family supports with the father or single parent situation, and mental health issues of the parent. So that was ours.
Very good. Thank you, breakout group 1. You did a great job. All right, breakout group number 2. Unmute yourself and report out and then remute. We have breakout group number 2. Breakout group number 3.
I'm not really sure if I'm really going to be the spokesperson, but because we appeared back before I knew it, but I will give our answers. So,
Thank you.
So, you know, as far as bonding opportunities, opportunities, of course, for time together, you know, opportunities for people to come into the home and help educate the mom, including basic care, as well as provide encouragement to continue getting stronger, better, and just in support for the skills. Going off of your instruction earlier, we said breastfeeding. We were also thinking things like baby wearing, so skin to skin contact, and of course when they're bigger, for carrier in the front. And you know, since they may struggle with sleeping, opportunities for rocking the child to sleep, kind of those quiet moments that a mom and child can spend together. In regards to you know, the child welfare system, you know, there's just a limited amount of time. You know, if you're talking about a removal for a parent-child to spend together, the environment in which they usually spend is not, you know, a more natural, comfortable one. And just the removal episode itself, you know, they're not able to go through the day-to-day steps of caring for a child. And that was all.
Excellent. That's great. Thank you so much for that breakout group 2. And breakout group, I think you were 3. Breakout group 4.
Hi. So we had lots of great discussion. We grouped the strategies in 3 big groups. One was increasing education in different places, like with the families, their support system, the hospitals, and all the healthcare professionals in the communities, just so everybody speaks the same language and knows what to do and how to respond to baby's behavior, and support mom and family and how to respond. Because there was a lot of discussion and what we've seen in the different settings and the responses. So there's a big lack of education there. The second one was in all those techniques of, how they repeating that skin to skin and how to soothe, and soothing techniques that everybody knows, and that will be easier to support the family, whatever they are, and to increasing that bond. And that has to do also with the breastfeeding and all of that. And then the third group is to improve the court system during the process of, all that process, so that the separation between mom and baby doesn't damage that relationship and then that bonding. So there is more engagement from the mom and the family in what's going on with the baby, and there's more opportunities there to reunite than to complete that separation and improve the lives of these families and not cause any more trauma. And then on the barriers, we had the lack of funding, and some of the agencies are overwhelmed and have very big caseloads, and the quality of not just the time, the length of the visits, or the quality of the visits. All of that will improve if there's more funding. The community everywhere, like the judging, the stereotyping, and it's everywhere, the healthcare system, the community, everywhere, they're just, stereotyped and judged. And then the third barrier will be the lack of information, and sometimes just lack of information related to everything that we spoke in the first strategy. And then, some other things like transportation and things that will make their lives easier if there were not such big barriers.
Excellent. Thank you so much, Breakout Group 4. Breakout Group 5. Do we have a Breakout Group 5?
If you don't mind, I'm going to go for 5. I don't know if I was 5 because I forgot to pay attention, honestly, to what group I was in. But at least I wrote things down and I'm speaking. Is that okay?
All right, that's all.
Okay, so I'm just going to wing it. Okay.
Okay.
So we were talking about, we actually had myself and another person participating. A lot of people were not really active in the group. But nonetheless, we were able to get it done. But what we had talked about is even just some of the slides that you shared today, like you said, it takes special training really to do infant mental health and really be able to facilitate that kind of psychotherapy that's needed. But even some of the slides that you used today, that kind of psychoeducation for the parent, which I'm sure you do as part of this process, I think is phenomenal, because knowledge can be power, right? So we said, so definitely one of the interventions we thought would be strategy we thought would be helpful would be that ongoing psychoeducation. So they have a base of education, so they understand almost what you're teaching them and how it reflects to some of that psychoeducation. We love the whole idea about all the in vivo exercises, whether it's the breastfeeding, whether it's the reading, the social cues, and that exchange in social cues, and even teaching, even for us as parents to be aware of our own facial expressions and how we're responding to the baby, because it's going to then, impact the baby's response to us sometimes, a lot of the time. So we talked about that. We thought that was a phenomenal strategy. And then also, the more services that the parent is amenable to receiving, and the more social supports they have, whether, economic supports, mental health supports, even housing support, what have you. We thought, the more social supports the parent is receptive to receiving, that is going to obviously be a benefit to the dyad. And then also we talked about how important it is, you're right, that if there's a partner that's kind of on the periphery, to the best of the system's effort to get that partner involved, because they're definitely part of the family system and that dyad. So that was the the strategies that we had spoken of, and then the barriers. We were talking about the same thing, is that you even had pointed out during the training that there's a barrier in just having a nighttime nurse or some respite for a foster parent that is dealing with with an infant or a baby that doesn't sleep well. The sleep patterns are off, and how important sleep is. So that's just an example of resources, and you have a phenomenal program, but then there are certain pieces there's gaps of those services, and so to have the funding to fill in those gaps obviously would be phenomenal. But as we know, in working in social services, there's usually gaps. And then even just the community's lack of understanding, because we think at least some of us that are a little bit, say for me, a little bit older, remember the days that if a baby was born positive, that the baby was instantly removed from the mother, and that can be very disheartening for the parent, because obviously the best case scenario, whenever possible, if the family can work toward health, is for the child not to end up with their life in the foster care system, because that's not going to benefit anybody. And then the last barrier we talked about is, I'm glad and happy to be in the training today, but maybe the lack of training for social services providers and paraprofessionals who may have a more punitive view as far as the parent that has a baby that's born exposed in utero, and maybe a greater understanding of all those working in the system, because I think that they will instantly approach the parent in a different way from the second that she's either pregnant or giving birth and she's known to have been using. So that's it.
Well, that's a lot. Thank you so much for sharing that. You guys did a great job. I think we are on breakout room number 7. Breakout group number 7, unmute your reporter, unmute and report out, please.
Okay, I was in breakout room number 7, and we just started talking. We didn't even designate anyone, so I'm gonna give a stab at it.
Okay, that's great.
Possible strategies, some things that I was thinking, oh wow, this is not rocket science. Establishing a bedtime routine, or trying to, for those that are able to go to, have their child with them, doing that on a regular basis, eating meals together, decreasing screen time or stopping screen time for a significant amount of time. And then we also did we actually talked about more skin to skin contact was another one. And then barriers, there was mention of, for those that are working, there's unsupportive maternity leave, like you have to get right back after you have the child. So that definitely inhibits the parent-child time. Some people are working multiple jobs, so then there's very little time to do that. That's a barrier. And definitely, I think it was mentioned before about the lack of education of providers. Providers are understaffed. Some of the other things that were mentioned previously.
Okay, super, great job. Thank you so very much. And breakout group number 8.
Hi, everyone. For group number 8, we had a really good discussion, and some of the strategies that we came up with to support that parent-child attachment is, one, helping with talking for the baby, then eventually the mom, the parent, will be able to do that for themselves. And another one is education for the parent, the caregiver, on the ages and stages, the developmental milestones, so that way they're not misinterpreting when the baby is not doing this, or the baby is not doing this because she doesn't love me, because I'm a bad mother, but really, really focusing on those expectations for the parent. That can be very helpful to get them to understand, no, the baby is not doing this yet, not because she doesn't love you, but because she's just not there yet. Definitely including the social emotional development as well. And then a third strategy that we identified is following the baby's cues. That's really one beautiful way of developing attachment between the diet, the parent, and the baby, following the baby's cues. And then for the what's it called? For the barriers from the system's perspective is the first one we identified is fear of judgment. I think we think a barrier can be if a parent feels that they're going to be judged by the system, by other caregivers, by just society overall, that can get in the way of them really feeling free to do some parental behaviors that can definitely help in the attachment. The second one is the cultural perspective. One really good example that we thought of is in certain cultures, picking up the baby too much. The thought is that the parent will spoil the baby. But in reality, picking up the baby is definitely helping in the attachment. The babies don't really understand that they don't really have the capacity to manipulate a parent at a very early age. So when we think of that culture, no, don't pick up the baby because it'll spoil them, then that can definitely get in the way of bonding and helping with that attachment. And then the third one that we identified, another barrier, is sometimes parents don't feel, because of maybe things that they have been through, experiences, they don't feel like they have the confidence to be able to do what's right for their babies. So that lack of confidence can really also be a barrier in doing what's right and help with that attachment. That's
Excellent. You guys did a great job thinking this through. Thank you so very much. And breakout group number 9.
I'm not sure that somebody put in the chat that we weren't able to hear each other. We really weren't able to communicate. I did make a little list, but it's really a lot like everybody else's here today. I mean, I had encouraging touch, such as breastfeeding and bonding, attachment, providing external supports to the baby, the mother, and the family, parenting skills, education. And then looking at the barriers, I had just had like old rules, laws, and biases. Just like maybe prejudices, you know, I feel like that has to be in there too.
It does. It's very important. Good job. And I'm sorry you weren't able to communicate with one another in your group. We do have very few, but occasional IT glitches. And breakout group number 10. Do we have a breakout group number 10? Breakout group number 11.
That's me. So we actually just discussed some, we couldn't remember all the points, but we discussed some bonding ideas. And one thing was to have the mom, if she's struggling with bonding, to set a timer for every day for a minute and hold her baby face to face and just concentrate on observing the baby, looking at the baby, looking in the baby's eyes. If they find themselves distracted, to not consider it a failure, just bring themselves back to the baby and for that whole minute, and maybe try that for a week or two. And then another strategy was to have the mom write like a letter, I guess, or a journal, and just title it, I am like John's mom. Okay, what does that mean to you? What feelings come to you? How do you what do you think about? And just like a self-reflection kind of letter. And those are just 2 ideas that we had during our group.
Excellent. I like those ideas. Very creative. And our last breakout group, I think, is breakout group 12.
I think that would be the group I was a part of. I believe I was the only one speaking to the IT guy. A couple people checked in, but we don't know what really happened. But this is kind of what was explored with me and the IT. We looked at some of the things that other people already, of course, brought up. We looked at the fact of, first, we want to look at taking things from a strengths perspective, absolutely working with the family, and not just looking at baby age or toddler age, but just looking at parent-child relationship bonding overall. The strength perspective, one, doing a needs assessment to see really what does the family want and need from us coming in, because there's already a lot that they have gone through and a lot of pressures and mandates. Play therapy, actually, absolutely, play therapy with parent involvement. As we know, therapy is split mostly with the child. But we want that to be some parent involvement so that the relationship can be formed in that sense where the mom or dad is not just looked at as this disciplinarian, because if there's no relationship, there's no real bonding that's happening or parenting that's happening with no relationship with the child. Then we looked at, of course, psychoeducation, in essence of educating the parent in regards to what is relapse. You know, you have been through this this crazy substance misuse ordeal. What is parenting really like? What are some things that make you scared? What are some things that can help you in terms of building encouragement and having them feel confident? And of course, number 3 for us was community involvement in the broad aspect, because there's so much that could fall under community involvement, which will be that rapport building, case management, resources, community support, making them be able to bond and do things outside of the rooftop and the door that they are aligned in daily, and having that outside community involvement that's helping them to do things. And then for the barriers would be one, the major is the department, which department meaning the system, procedures, processes, where us as practitioners will see different things and needs that the family have. But because of the red tapes of bureaucracy in the department, it is hard for the practitioner to really do exactly what we know the family needs, because there's so much stuff going on. So that's one huge barrier with procedures and processes there. Having a block overall in working with the family because of stigma and mistrust that has developed in both dynamics. Mistrust from community, mistrust from society based on the parent who was had the substance misuse happening, and as well as mistrust being developed from the parent and that family, given how they have been viewed and are looked at and are being stigmatized by community, and not trusting practitioners or social services to come in and want to work with them, and having that failed rapport development. When there's no healthy rapport being dealt with, the family doesn't become as successful as they can be, because they're not trusting of the service entities that are definitely entering the home. And then the other, of course, is lack of support in general from community, lack of support in family. One of the major things we know with substance misuse and dependency is external support is very necessary in that family thriving and becoming as successful as they can. Lack of the resources such as housing, jobs, such and things like that. So they all like kind of go back as to how we will integrate, and then the barriers that are there. And that's kind of some of the stuff that I kind of brainstormed and came up with.
That is excellent. What a great list of resources and strategies and barriers you have all put together. And I'm glad this is being recorded, because I think this is very useful information we can all take forward and push up to our agencies to say we have some solutions. We know we at least can identify a number of problems and strategies that we can use if we join together and make this a united front. So thank you so much. I hope you had a good time in your breakout groups. It sounds like you had some very rich discussions that's contributing to everybody's attendance today at the training. So I appreciate you, and I thank you. Is there any group that did not get a chance to report out before we move on? Everybody good? All right, well, let's push forward here. And we're going to talk our next part. That we're going to talk about the short and the long-term developmental prenatal exposure to drugs and outcomes. And the short and long-term, that should say outcome or developmental outcome to prenatal exposure to drugs and alcohol. And what I said before is that the areas of the brain that are most impacted by alcohol and drugs negatively affect that development of the executive functioning. So we're going to spend a little bit of time on this. So those elements that are involved in executive functioning include focus, and that's your ability to concentrate and to focus on a task and to start a task and complete a task without getting distracted by external stimuli or your own thoughts, which can happen, or things that are going on around you. One very important one is cognitive flexibility, and that's being able to shift your thinking or think outside the box or adjusting to changing priorities. And it's funny because in the first 2 trainings that I've done, we had to exercise some cognitive flexibility, like the tornado warnings yesterday, to kind of work around that and say, all right, let's stop here and think for a second about how we're going to do this, and we're all going to stay safe at the same time. But that's that ability to say, this isn't going exactly as I had planned for it to do, or I thought that it would. So how can I think about something differently, about how to solve this problem or how to do this task differently? It's being able to be flexible in your thinking and to shift your thinking when you need to shift your thinking. Your working memory, that's that part of your brain called the hippocampus that we talked about, and that's holding information in your mind and working with it. For example, you're doing mental arithmetic or understanding a story, and you have to be able to shift, but also retain what you have learned from one problem and pull that forward to help you and assist you in another problem that you might have down the road. That's your working memory, that you can pull that up. And then inhibitory control, which I think is, incredibly important, and one of the things that we see that is really can be very, very problematic in individuals that have been prenatally exposed. And that's, that ability to go off pilot and do what is appropriate, even though you want to do something else. You've got to be able to inhibit your impulses. Like, you cannot just, say, I have to do this training today. Oh, but I just want to go up to, I want to stop and go out to the beach right now. I can't do that, even though I want to do that. I have to inhibit that impulse to be able to do that. And inhibiting and controlling our impulses is, if we cannot do that, we all know we're going to be in some significant trouble, often trouble with the law, if we can't control our or need or want to take something that doesn't belong to us from a store, or hitting somebody. I mean, anything. That inhibitory control is so important. And then this is just a slide of your brain and how executive functioning works. The frontal lobe, this yellow front part of your brain right up here in your forehead, behind your forehead, is responsible for much of the executive functioning of the brain. And these functions include attention, working memory, planning and organizing, forethought, and impulse control, all the things we really just talked about. All of these things need to be under control, need to be working in order for us to be fully functioning human beings. And the brain actually develops from the back, from where you see the cerebellum back there, up to the frontal lobes. And the brain develops from the bottom, from this brain stem that you see way down there at the bottom, all the way up to the top, to the parietal lobe and the frontal lobe. The frontal lobe is the last developing part of your brain, but the most significant in terms of how we function in the world. So if there's been brain impairment due to exposure to alcohol and drugs, you're going to see the effects of that in the frontal lobe. It's not going to be fully developed. It's not going to be well developed. And so these kinds of functions that are critically necessary for living a successful life are really going to be impacted. And then some other areas of the brain involved in executive functioning, that prefrontal cortex works in concert with other parts of the brain. It's like we used to think emotion was in one central part of the brain, as the limbic system. We now know that every single part of the brain has something to do with how we feel and how we emote our emotions. And this prefrontal cortex works in concert with the anterior cingulate and the parietal cortex in the hippocampus. The brain works as a whole. There is not one part of the brain that does only this or only this or only this. The brain is like an orchestra. It needs every piece, every instrument doing its part to come out with this beautiful song or this beautiful piece of music. So the executive functions are a set of processes that have to do with managing oneself and one's resources in order to achieve a goal. This is what I'm setting as my goal. Here's my plan for how I'm going to carry out my goal. I'm going to evaluate my plan and see if my plan was effective. Is there anything I would want to change in the future and do differently around my plan? It's that whole planning process and goal-oriented process. It is an umbrella term for the neurologically based skills involving mental control and self-regulation. And self-regulation is so important throughout our lifetime. We can't, if we go through life not being self-regulated, we're going to have a lot of challenges, a lot of difficulties. And one of the things that I'm seeing in our kiddos, and I've been seeing for quite some time, really, even actually before the opioid epidemic hit its peak, is a lot of our kiddos are coming into our preschool setting at the Florida Center, the Starfish Academy, having been expelled from 3 or 4 different preschool settings before they get to us. And I'm talking about 3-year-olds, 4-year-olds, 5-year-olds. And the primary reason they're being expelled is because of their inability to self-regulate. Their impulsive behavior, their sometimes aggressive behavior, but it's that self-regulation piece that is so impairing their ability to learn and to behave and to do the things that we expect them to do at their ages. The insular cortex, which is involved in perception, processing, and emotion, is also influenced. The insular cortex plays a role in personality disorders with skewed perceptions, including borderline personality disorder, which we all know is common in adults with behavioral health issues and nurture and attachment challenges, as well as what we're seeing in some of the NAS developing children. The insular cortex of the brain can be influenced primarily through the prenatal period during gestational age 13 to 28 weeks. And remember that side of your fetal development. There is really no safe time that brain is not being impacted. So if it's 13 to 28 weeks in fetal development, that insular cortex is highly vulnerable for insults. And that can play out in how we perceive things, how we process things that happen. And children with fetal alcohol exposure in particular have a lot of challenges with perception. They often perceive things, what we would say, incorrectly. They will tell you things that didn't happen. So they get all kinds of labels like liars or psychotic because they say they're seeing things or they're hearing things, or their perceptions are just distorted. You can have the same experience and be in the same room. And this has happened so many times with Seth, especially when he was younger, and he would say something happened. And I would say, that didn't happen. And he'd say, yes, it did, Mom, I just saw it. And so we would have, and it was hard for me to understand what was actually taking place. And the first thing is you want to say, oh, you're not telling the truth, you're lying, right? Because that's what you think. And then I had to understand, and I had to understand processing and perception. And it's brain. It all comes from the brain. It's everything we do every minute of the day is about our brain. And we often forget that it's about our brain, but it's about our brain. And so having having him, it helped then to sometimes even role play an experience and say, what did you see that just happened right now in what we were doing in that role play? What did you hear and what did you see? And the more we could kind of do that and walk through it, the better he got at it. And now I would say it's very rare that would occur. So there are strategies that we can teach and use with individuals that have perceptual problems, any of these problems. The great news is there are strategies and they can change and they can learn and they can make advancements to an optimal level of development, whatever that might be for that person. And so some of the layers of self-regulation, and I've said this 2 days in the other slides, I have this wonderful slide and I don't know why I didn't put it in, but it's a pyramid. It's a pyramid of self-regulation. And down here at the bottom of the pyramid is your sensory system. It is the foundation of the pyramid. It is where everything starts in your brain. It's in your sensory system. And your sensory system actually begins developing from the moment of conception and continues. We used to think it continued into the 20s, and now the occupational therapists are saying it continues through a lifetime. And even when your senses, like your hearing and your sight, begin to diminish as you get older, they are putting in a lot of occupational therapy strategies that they use with children to help improve those sensory systems as we age. And thank God Almighty is all I can say for that one. And so, but at the bottom, at the base of this is your sensory system, then your emotional regulation system, and then your motor coordination system moves up. At the very tippy top of the pyramid is behavior. And unless all of these lower things in the pyramid are functioning at least marginally well, you're going to struggle with behavior. And learning is right under behavior. So we want them to be very smart. We want them to follow the rules. We want them to behave, but we're not thinking about all the gaps that might be all the way down the pyramid, starting at the base, which is the sensory system. So the layers of self-regulation, at the bottom, we have basic physiological regulation, and that's being able to regulate and control your bowels, your breathing, your heart rate, your sleep-wake cycle. That's a part of your physiological regulation. And remember, that's off for many of these kids. Your ability to regulate your food intake, to feel hungry, to know when you're full. And then your attention regulation, your ability to attend, pay attention, and learn. Your emotion regulation, your ability to control your emotions and not be explosive or overreactive in situations. Your behavior regulation, you can control your behavior. And then your executive control. You can control your thoughts. You have control of your thoughts. Your thoughts are not overtaking you or getting out of control of things that are not real, that are taking place around you. So we're going to come back and we're going to talk more about self-regulation and how that is impacted by prenatal alcohol and drug exposure. But right now we are going to take our second break in our training today, and that is a 15-minute break. We are right at 4 o'clock. I timed this well. And so we will return at 4:15 and finish up our presentation for today, really talking about self-regulation and a couple of other things. You'll have one short group activity, and we'll be ready to, and the time has gone so fast. I can't believe we've already gone through 3 hours. So go take a break, again, stretch, get something to eat, get a snack that alerts you. Yeah, that helps you to stay awake and be alert, and get something to drink. And we will be back here at 4:15. Hi, welcome back from your break. I hope that you were able to stretch and get a little snack to eat and get some refreshments. So we are on the home stretch of our training today. And so we're just going to continue here, and we will end right at 5 o'clock so that you can get started on your weekend. I don't know about you guys where you live, but it's an absolutely gorgeous day here. And I think I'm going to take a nice long walk when this is over and get some fresh air. So we're going to cover like what impacts a baby's ability to self-regulate. So what we know is that almost all individuals prenatally exposed to substances, and this is of all kind, experience sensory processing issues. And in all of the kiddos that I have evaluated over all of these years, I don't think I've ever seen one that hasn't had some sort of a sensory processing issue in one or more of their sense areas. And these issues, and we often misinterpret sensory processing issues for willful behavior. I can't tell you how many times we don't even think about, most of us don't even really know about how important our sensory processing system is. But what we can see in children, and sometimes even adults with prenatal exposure, is total shutdown when they get into this sensory overload, or just very disorganized, out of control behavior. We can see emotional lability, which can be emotions all over the map. We have kids in the classroom that can be laughing 1 minute and crying hysterically the next, and there does not appear to be any rhyme or reason to what happened. Irritability, emotional instability, difficulty in interpersonal relationships because they're not able to really read and process each other's cues, learning problems, behavior problems, poor self-esteem, and perceptual problems, which we talked about. So this is just a great little graphic of the effects of poor sensory modulation on learning and behavior. So most of us, most of the time, operate in the middle here with normal sensory modulation. We can take in information from all of our senses, we can kind of sort it out, figure it out, and then get ourselves in a state of being able to give a very adaptive response. If our sensory system is messed up, we can either be underreactive or we can be overreactive. And sometimes we can vacillate between the two. And so in the underarousal group, what we see is that they miss nonverbal cues. They can have very slow affective responses and verbal responses. So it might often appear like they're ignoring you. There's all kinds of negative things that we say when children do these things. They're ignoring me, they don't want to pay attention, they could if they wanted to, but they're just in a different kind of sensory state than we are. In the overreactive, we actually see overarousal, and that they overreact to nonverbal cues, they're anxious, they're too alert. These are the kind of kiddos that are sort of like hypervigilant or hyper alert. And if even something drops in the room, they can be startled by that very easily. In the underarousal group, they need large amounts of stimulation to arouse them. They need help in getting their sensory system up into the arousal level. And if they're in overreactive, they attend to all stimuli as much as possible and have a very difficult time filtering anything out. Both of overarousal and underarousal can lead to impaired social behaviors, and that can lead to defective attending behavior, the spacey and slow on the underreactive, and the distractible and fragmented on the overreactive. So they have defective attending behavior. They can fail to look at you. They have a really hard time with eye-to-eye contact. And sometimes when we are disciplining children or correcting or whatever, what's the first thing we say to them? Look at me. We should never, ever, ever do that, because eye-to-eye contact, facial contact, seeing facial expression is the most stimulating thing on the face of the earth. So when they're in this impaired sort of sensory modulation space, looking at you or demanding that they look at you can actually drive them into further underreactivity or further overreactivity. And then as a result of all of this, learning is impaired, definitely behavior is impaired, ability to relate is impaired, all of those things that we've been talking about. So what does this look like in infancy? Some of these things we've already covered: the poor sleep patterns, the difficulty feeding, the fussy, irritable temperament, prolonged crying, the difficulty in soothing or comforting, this sort of overreactive or underreactive to stimuli or situations. And all of that results in difficulty forming attachments. Remember, attachment is brain-based as much as it is environmentally and socially based. And if all these things are happening in the brain and the brain can't modulate, it's not going to have the capacity to relate and to attach. And when Seth was a baby, he was in this, and we got him at 4.5 months, but I would say well into toddlerhood, we had those calm, modulated moments were very few and far apart. He was either asleep or kind of non-responsive, and there was a while when we wondered if he maybe was autistic, and then to complete and total out of control. It was just all over the map, and no predictability to it. No way to say, well, this will absolutely set him off, or this will absolutely set him off. Then in toddlerhood and early childhood, what we begin to see are the behaviors become more prominent. And we can see aggressive behaviors. Seth was a major biter, huge biter, highly active and impulsive. And I want to say take ADHD and multiply it times 10. And that's what I'm talking about. Poor attention span or no attention span. Very disorganized, no sense of danger. We had to have eyes on Seth 24/7, especially after he started walking, because he went from walking to running very quickly. And then the impulsivity and just really almost got out of control. Poor sleep patterns still consist to this very day. Pica, everything went in the mouth, and some of it he swallowed. Self-injures, he was a headbanger, and absolute fight and flight behaviors. And that's because their arousal system is always on alert. They always feel in a sense of danger. They always feel fearful around them because they're not regulated and grounded in their sensory systems. So you can see, and I see this in a lot of our kids in the preschool setting, it's fight, they become aggressive, or it's flight. They're under the desk, they're behind in a cubby, they have a blanket over their head, and you can't learn in that state. When you are in that state of fight and flight and high arousal, no learning is taking place in the brain. You couldn't if you wanted to, it's impossible. So what contributes to these behaviors? One of the things that I want to get across to all of you today is that these are brain-based behaviors, BBBs. And start using that word wherever you go when people are criticizing children's behaviors or whatever, and you know that they've been prenatally exposed. We all have to start reframing this and saying this and teaching this. These are not willful, disobedient behaviors that are trying to make you crazy, although they might be making you crazy. These are brain-based behaviors, and it's related to the prenatal exposure, which impairs the brain, the central nervous system functioning. Environmental factors we talked about can certainly compound the problem. If you've got domestic violence, if you've got neglect and abuse, poverty, teen or single parenting, parental substance abuse, all of those things, that's going to make it sort of like a double whammy and be much harder to get under control. We know that multiple disruptions from foster care, from relative or foster care placements due to behavior, disrupts attachment and is critical to sound social emotional development. So again, maintaining these children in their homes, in their foster homes, and there's a lot of failed adoptions with these children. So being able to provide the necessary services and supports to the parents, to the foster parents, to the adoptive parents is really critical. And it's really critical throughout adulthood. We're getting, we get calls from all over the country of like, I have a 32-year-old brother and he's never been diagnosed, but we think he has fetal alcohol syndrome and we're trying to manage him and he's in and out of jail or he's in and out of jobs. They need caretaking for all of their life. They need someone to watch over them and protect them. And then what we can see in latency age is this poor cause effect relationship. They do not get, if I do this, this will happen. That can get them into serious trouble in school, as well as trouble with the law. They do not understand rules or consequences. They can tell you maybe what the rule is, but that doesn't mean that they understand the rule or that they can follow the rule. They can be anxious, they are highly fearful, they can take things that don't belong to them, and we often call that stealing, right? And we had a situation with Seth when he was younger at Oak Park School, which is a school for children with special needs in Sarasota. And they went on a CBI, a community-based instruction, I used to call them field trips, to Publix, our grocery store. And at that point in time, Publix had these candy containers out in the open, sometimes with the lids up. Well, Seth saw the candy, put his hand in one of the things, took out a handful of candy, gave it out to his friends, and you would have thought he robbed the store of all of their money. Total overreaction by the teacher. Took him up to the manager, made him apologize to the manager. She wanted to call the police in, and the poor boy was absolutely terrified and traumatized. He was really traumatized by this for a very long time. He did not want to go into Publix after that for months, and he loved going shopping at Publix. And he still talks about that day where he took the candy he wasn't supposed to, not understanding, the ramifications of that. So the rule of that is don't have the candy out in the store where kids can take it. They can tell stories or fabricate when they're not sure how to answer. The very worst question you could ever ask them is, why did you do that? Because they have no clue why they did that, but they can make up the most preposterous answers, and trust me, I think I've heard them all, or stories about why they did that. So the adult needs to learn, you don't ask why, you just walk through what the consequences of that are and the natural consequences. This is a problem because they can have poor abstract thinking, tend to be pretty concrete thinkers, again, poor social skills and poor sensory processing. As they move into that adolescence and adulthood, the worst thing in the world that kicks in is puberty. And I swore to God when Seth hit puberty that God should not have ever allowed that to happen for children with developmental disabilities, because their hormones get out of control, and it just becomes much more challenging for them and for their caregivers. They often cannot manage daily living skills without adult supervision. They can be overly friendly with poor physical and verbal boundaries, and that is still an issue for Seth sometimes. He's very friendly. He loves everybody. He'll go up to them. He used to hug them. We say, we've broken that. But he'll talk to anybody anywhere, which can be dangerous because it can cause him to be easily victimized. And all of these individuals are in that same sort of bag. Poor judgment, which can get them into trouble. Very easily influenced by peers, which again can make them easily victimized. Again, they might be able to state the rule, but they cannot follow the rule or understand the rule. And they can have some very high verbal skills. Seth has a very high vocabulary, but he doesn't understand what all of it means. And he can have high vocabulary skills, but poor thinking skills. And again, be impulsive. And that poor sensory processing really stays with them for a very, very long time. And this is a great slide that I love by a dear friend, Dorothy Schwab. She's an occupational therapist out of Canada. And she is the only OT that I know to date that has written an article specific about sensory processing problems and sensory integration as it relates to FASD, fetal alcohol spectrum disorder. And when I saw the first time I said this, I'm like, oh my God, this makes perfect sense. So in normal sensory integration and sensory processing, we have this little executive brain guy, the sergeant at arms in our head, in our brain, that is able to take in all of this information from our senses. And that's how we learn. We learn from taking information in from all of our senses. And we're able, with the help of this sergeant, to integrate all of these different sensations and stimuli that we're getting in all at the same time, process it, give it meaning, give some meaning to it. And in a relatively short period of time, if we're processing well, we have our output. And our output is good. It's functional. It's adaptive. It's socially acceptable. And we can attend, we can learn, we can interact with others and the environment. We have good coordination and movement. We're not clumsy. We have good self-esteem because we're getting reaffirmed and getting affirmations and positive reinforcement for how we're acting and behaving with other people. We have good self-control, and we can control and express our feelings in an appropriate manner with others. This is the brain of someone with disordered sensory integration. And look at that poor brain. There is no sergeant at arms in the middle that's sort of directing people and taking in this stimuli, all of this stimulation coming in from all of our senses, our taste, our touch, our sounds, our proprioceptive system, our vestibular system. There's no processing going on of all of that stimulation. There's no integration of all of that stimulation, and certainly no understanding of all of that sensory information. So what's going to happen? What's our output? This is our output. We are in sensory turmoil, chaos, and or apathy. Again, it's that we overreact or we just shut down. And one of the things, when I first saw this slide, and this was many years ago, I was so struck by the drawing of the tornado, because when I opened an FASD clinic at the nonprofit I was at in Albany, New York, and started working with children in a totally different mental health way. You don't do mental health treatment with these kids like you do with kids that don't have prenatal exposure, but you can do it. You just do it from in a different kind of sort of way. But when I would ask these children to draw how it feels inside their body, I would honestly say 90% of them drew a tornado. And I was fascinated by that. And I'm like, why is there so much consistency in what these kids are drawing? Well, this makes perfect sense. It's like a tornado. So imagine being in their body and certainly being in their brain. And this is what life looks like to you most of the time. How are you supposed to navigate that successfully? So I want you to kind of keep this picture in your mind, because it will help you when you're trying to understand and work with these children, what might be going on with them. And in terms of treatment, my treatment approaches with these children, and I work with them from the ages of 3 on up, and some of it's all dyadic work, but I do some individual work around their areas of specific deficiencies, and their parents are always with me in the session. And it's really working. I always start with the sensory base. I do a sensory practice with them to ground them. We are always on the floor. We are never in the chair or at the table, because being low to the floor is grounding. It's what we all need to do when we're disorganized and disoriented: hit the floor. And then a sensory processing activity with clay or whatever, or soft music. I use a brushing activity to help them get modulated. And then I talk about emotions. It's sort of like where you're going up that pyramid. Let's learn about your feelings. You know, here are some pictures we're going to cut out of being happy and sad and mad and scared, so that they can begin to identify how they feel, and they can learn this. And then they can begin to identify emotions in other people. And then we work up that ladder to some problem solving and some cognitive concepts like idea. I have an idea. Let's make a plan. Those are two executive functioning things that 4-year-olds, if you work on this, 3 to 4-year-olds can get it. And then you've got them starting off into a very great path. And I am watching my time. And I just wanted to add this screen because it is so very, very critical to remember that when you are working with these individuals, that this doesn't go away. It goes into adulthood. It might, some of it may die down a little bit, but it still impacts their ability to think and their ability to relate. And we are now screening adults. Our FASD program was really going to be for children, because that's the Florida Center is for early childhood. But we were getting so many referrals from our adult treatment program saying, can you take a look at this 32-year-old woman? We're pretty sure she has FASD. And sure enough, she had FASD. And they would report to us, these are the people in the unit that are not doing well at all. They can't reach their milestones. They can't fulfill their plans. They can't have a success. They can maybe work really hard to make their level, and then they're back down 2 days later. And this is why, because they have those poor cause effect. They have poor working memory. They're concrete. Level and point systems are concrete. It means nothing to them. And they need a person to be that external brain for them. They really need a coach, a supporter, a prompter, someone who can walk them through the process or help them stay on task or keep appointments. And they require a great deal of acknowledgement and reinforcement with every success. And they really respond to positive statements and to add, reinforcement. They really do. That's a motivator for them. That's a motivator for all of us, but it's a very high motivator for them that can be very effective. So we are now, it's 4:37. We are going to do a second breakout very briefly, 10 minutes. And I want you to select a spokesperson and just do one of these. Either collectively come to a consensus about one thing you will do differently in your practice with the knowledge that you've gained today, or what is your biggest takeaway from today's training. So if you can reach a consensus on that, or at the most 2, in 10 minutes, we're going to come back and have a very fast report out and finish up the very few rest of our slides that are left. So our dear IT team, if you can help get us into breakout sessions, 10 minutes, and we'll rejoin. Thank you. Okay, welcome back. And now we are going to just report out very quickly. I'm not going to call you out by group, but if you will just unmute yourself and give your group's consensus of either one thing you will do differently or your biggest takeaway from today, that would be great. And we'll move this through pretty quickly. So if you're a reporter or if you're in a group and you want to report, just unmute, tell us what your takeaway is. Or what you'll do differently, and we'll just go through this with our groups.
Hi, thank you for the presentation. Hi, I'm Brenda Durbin from the coalition. Can you hear me?
Yes, we can, Brenda. Thank you.
Hi, what I am taking away from this is your by the way, thank you for the presentation. And what I'm taking away is especially dealing, because I'm an intake coordinator, so we deal sometimes with women with substance abuse. And so the way you explain it, it's making me feel more compassion for them. And like you said, the resources that we can get for them and help them. So that's what I'm going to do differently, trying to help even more.
Excellent. Thank you so much. Anyone else want to share?
Hi, good afternoon, everyone. I'm Eileen, and I was part of group 1, and we had some really good feedback. One of the things that we spoke about is really the importance of advocating for mom to have that uninterrupted bonding time with their child to build that positive attachment, and also having more empathy for the mother that's going through this. We also found very interesting that the highest risk group for binge drinking was women in their 30s with college degrees. We normally see this population as being very low risk, so it is an eye opener and definitely something that will be taken away. Thank you.
Thank you so much for sharing that. Anyone else want to share?
One thing that, well, two things that in our group 5, we're taking away is one, the significant impact of educating our caregivers overall, mothers, fathers, caregivers on, well, mostly parents, on the risk of substance use. Also speaking about, also including the paternal use, even though we always speak about moms, the pregnant mothers that are exposed, I think we also consider the influence of the paternal exposure having an effect on the baby. And another thing that we're taking away is the words that we use when we assess for this exposure. A lot of times moms can deny the use because they're feeling they're going to be having their babies taken away or just a stigma. So another good thing that we're taking away is wording, the wording that we use in assessing for this problem.
Excellent. Thank you so much for sharing that. Anyone else want to share? We'll take a couple more shares and then we'll move on.
Group 4, we came up with bringing in the early childhood court sooner, sharing with those working with children, especially DCF, adoption units, looking at the case histories and stressing more alcohol consumption, not just listing all the other drugs, increase public awareness about impact of drinking in pregnancy, and highlighting these points with pregnant mothers programs and colleagues.
Excellent. Thank you so much. We'll take one more share. Anybody else want to share?
In my group, we had like the shock factor, like all of this information is new to a lot of us, and change the perspective on how we see these families and moms, and how created like that sense of we need a commitment to, in our practices, to become more sensitive and more mindful of how we're doing things. And some people have direct support to DCF workers, where changing that kind of view of the families will also change the way they support the DCF workers, and the need for a lot more education. And the more you know, when you discover something, the more you know, the more you feel like you don't know anything, and then you need more training. So the need for
more personal training to be more capable of supporting families in doing our own work in the different settings.
Excellent. Thank you. Well, you had great discussions, it sounds like. Thank you so much for sharing out your thoughts. And I'm so happy to hear so many of the takeaways that you're taking away from today. So we're going to finish up our slides here. One of the wonderful things that we're seeing taking place across the country right now due to federal legislation are safe plans of care for babies that have been prenatally born with substance exposure. And FASD has now specifically been included in that classification as well. And I'm going to be talking a lot more about safe plans of care in my December webinar. So please tune into that because I've got some really good information to share on those. But we need a safe plan of care for the baby, a safe plan of care for the mom, but we have to remember to have this safe plan of care for the dyad as well. Critically important. And then we all know this, with the right interventions and coordination of services and supports, and with the right attitude. I think attitude is really important, and perspective, and that sense of compassion for the walk that they've been through, that we can change the family's trajectory and we can stop all of these cycles of just social maladaptation that's taking place. It is possible. I know it's possible. I've seen it way too many times to say that it's not. And parents sometimes say, well, when do I know to get help for my child? And I'm going to jump down to the fourth bullet right there. Your child's pediatrician is your first go-to. They'll have your prenatal, your birth and neonatal history and refer you to early intervention services. All of these babies need, and especially if they're in foster care, it's a mandate to be screened by early steps, but then to be followed up on, because the eligibility for early steps has changed, and they might look okay in the first 6 months or even the first year, but those follow-ups need to continue. And if a parent is just worried and saying, I just don't feel like this is typical behavior, get reassurance. If you feel more reassured, you're going to be able to engage and feel more confident in your parenting. Somebody said knowing what's typical development and helping them to understand that so they know that if something is not typical development. And then those early intervention services, the earlier we can intervene and the faster we can intervene with the right interventions, the outcomes and the prognosis for these individuals is huge. It's monumental. So right now we're going to watch a very quick video because it's excellent. It's only 4 minutes, but I really want you to hear this doctor's message.
At any one time, we may have anywhere from 10 to 15 babies in the hospital that were subjected to a substance in utero, many of whom are withdrawing or have neonatal abstinence syndrome. And typically what happens is these babies are stabilized in the neonatal intensive care unit for a day or two, and then transferred to the newborn nursery, where they're then, if they have to be, they're treated with some pharmacologic form of intervention. Over the years, we've realized that there are a number of issues associated with this approach. If you have to start pharmacologic therapy, babies may spend up to 3 or 4 weeks, sometimes a month or two in the hospital while we're trying to wean them off that pharmacologic treatment. Which increases the length of stay, increases costs, increases the time of separation between mother and baby, etc. The approach to the treatment of these babies should be initially non-pharmacologic. In other words, the treatment, and we've seen this recently, the standard of care should be keeping those mothers and babies together as much as possible. So there are many programs throughout this country that are using the mother as the first line of therapy. In other words, they're allowed to breastfeed, they're allowed to stay as long as they can with their babies, holding their babies, rocking their babies, much like what we have to do in the newborn nursery or in the intensive care unit using our own nurses. And if we can focus on that, many times it has been shown that we can perhaps not have to start using medications to treat these babies' withdrawal. It's really just trying to focus on keeping mothers and babies together. Even if we have to use pharmacology, it has been shown that the amount of medication that we have to use is a lot less, and that the length of stay in the hospital can be reduced significantly by using this approach, the non-pharmacologic approach. It also requires the destigmatization of substance use in pregnancy. In other words, much more of a supportive role for these mothers as they're going through this transition period, especially in the early postpartum period when this baby may have some withdrawal. It's a disease. And so, smoking is an addiction. Diabetes is a disease entity. And as I was trying to say earlier, if someone misses their insulin treatment, or if they're a so-called brittle diabetic and they develop diabetic ketoacidosis, we're not going to stigmatize those people and discharge them from a clinic because they missed their insulin dose. It's in the same way, if this mom relapsed because of whatever pressure she's developed from the outside and has gone back to using more substance before, these are the people that need our help the most, that we need to bring them back to compliance. And instead of stigmatizing them and allow them to continue with this habit.
Okay, I just think that's a very powerful. I'm getting some feedback. I'm not sure from where, so please mute yourselves if you're not muted. And just to summarize our workshop for today, there is no safe time or amount of drugs or substances that can be used during pregnancy. Remembering all women and fetuses metabolize drugs and alcohol differently. So being able to predict what the short and long-term outcomes are is not possible. And there can be lifelong risk associated with prenatal exposure. And supportive interventions are necessary for parents and child to negate adverse effects and promote the most optimal outcomes for mom and dad and child and the relationships. And you will have a list of resources available to you. We don't have, unfortunately, time right now to take any questions, but you have my email address. Please do not hesitate if you have any questions or comments or want additional information on anything that's been presented today. Just please email me and I will get it to you. And my last slide is thank you. Thank you first and foremost to all of you for taking the time to attend today and to learn. Go spread the word everywhere that you've learned today and use your takeaways. And thank you to FATA and thank you to the Department of Children and Families. And a very big thank you to the fabulous IT team who has been wonderful throughout these 3 very unexpected and sometimes unusual training days. So I'm going to turn it over to Rebecca to close this out. You all have a beautiful, wonderful, and blessed weekend. And thank you.
Unfortunately, this is all the time we have for today. We have included Catherine's contact information so that you may contact her with any future questions. Catherine, we really thank you for all the work you put into this workshop and all the valuable information you have shared with us today. We are sure this workshop will help practitioners better serve those struggling with the disease of addiction. As a reminder, if you want to receive continuing education credits or a statement of credit for this event, you must register with FATA's website at www.fata.org and create a profile. Please make sure you use the same email address you used when you registered for this workshop. At the sign-in menu, select Haven't Registered Yet, and you can register as a visitor at no cost. When creating your profile, please remember to use the same email address you used when registering for the workshop. After the workshop, you will have an opportunity to complete an evaluation of today's presentation. Your feedback is very important and most appreciated. If you want to receive continuing education credits or a statement of credit, you must complete the evaluation. The evaluation link will be sent to an email address you used to attend today's workshop. The sender will be training@floridabha.org with the name Florida Alcohol and Drug Abuse Association. Please remember the evaluation will close at midnight on Thursday, November 4th. When completing the evaluation, please remember to use the same email address you used when you registered for the workshop. As a reminder, up to 3.5 continuing education credits will be available if you meet the attendance and evaluation requirements. Please note that posting your credits can take up to 30 business days after the evaluation window closes. Again, that deadline is Thursday, November 1st. The recording of this presentation and presentation materials will be available on our website within 30 business days. You may access it on FATA's website. Once again, Catherine, we'd really like to thank you for presenting to us, and we would also like to recognize and thank our attendees for participating in today's workshop. Thank you to the Florida Department of Children and Families Office of Substance Abuse and Mental Health for supporting today's training. Have a great rest of your evening.
¿Qué estás haciendo? ¿Qué estás haciendo? ¿Viste cómo nos siguieron? Nos persiguen. Ya. Ay, la mejor parte al final. La mejor parte al final. De las cosas que decían la gente. Bobería. Bobería, Melón, tú sabes cómo es eso. A la gente le gusta